So we'll start with the risk stratification of the prostate cancer. And next, please. Very low risk. So Dr. Neeraj, can you start with the very low risk criteria? Who all patients will be in the very low risk region? Dr. Neeraj? Okay, Dr. Afroz? Hello? Hello?
Dr. Puneet, Dr. Ajay has raised his hand.
Okay. Dr. Ajay, please, you can start with it.
Sir, a very low risk is a part of NCCN prognostic classification of prostate cancers, and that would include T1 to T2A disease if it is a clinically stage disease, and if the PSA level should be less than 10 nanogram per ml, and the Gleason score should be up to 6, and if the
it includes PSA density also. So PSA
yes, sir.
density should
There
be
are two more. Yes, sir. There are two more things, sir. The PSA density should be less than 0.15 nanogram per ml per gram of the prostate, and the number of biopsy cores that should be less than 50% in each, sir. The number of
and that
amount of tumor in each biopsy core should be less than 50, and less than 2 biopsy cores should be positive.
3 cores.
I'd like to add, sir.
Yeah.
It's T1C. It's not T1B up to. It is T1C, and Gleason score less than equal to 6, and PSA less than 10, and 3 cores would be less than 3 cores would be positive, and less than 50% should be positive, and 50% should be positive, and PSA density less than 0.15 nanogram per ml.
Yeah.
This is very low risk.
So that's the very correct, very low risk. Moving on to low risk. Next, please. So low risk. We'll start with low risk.
I'll tell.
Bilkul, sir.
Low risk is T1A and T2A, and PSA score is less than 10, equal to 10, and Gleason score is less than equal to 6. And the difference between very low risk and low risk is that less than 3 cores would be positive in very low risk, but it is not in low risk. And less than 50% cores would be positive in very low risk, and PSA density. That is the difference between very low risk and low risk.
Anybody wants to add?
And sir, in both these cases, whether it is very low risk or low risk, all of the criteria should be present, not one.
The rest should be present.
One is not off. All of them are. So anybody else who wants to add?
So we further categorize patients on the basis of life expectancy after categorizing them in very low risk or low risk.
Please be a bit louder.
So we categorize the patients according to life, further categorized in very low risk, we further categorize according to life expectancy.
No, we are not going there. We are not going there. We'll stick to the very low risk and low risk. Okay. Next, please. Next, coming on to intermediate risk. So we'll start with the intermediate risk.
May I, sir?
Yeah.
Sir, intermediate risk, according to the NCCN guideline, they have divided into favorable and the unfavorable categories. And for the favorable, there can be any of the following. Unlike very low and low risk, there could be T2B to T2C, or the Gleason score. Gleason score should be 7, 3 plus 4, 3 plus 4, 7, and then PSA should be 10 to 20 nanogram per ml. And for intermediate unfavorable risk, they have from T2B to T2C, but Gleason score, it can be that 4 plus 3 is equal to 7. The major pattern should be 4, and the PSA should be 10 to 20 nanogram per ml. So any of the following will be
Any of the
categorized
following
as
will do it.
I'd like to correct, sir. In favorable intermediate risk, Gleason score is 3+4 and grade group is 2. And unfavorable intermediate score is 4. Gleason score is 4+3 and the grade group is 3. That is the difference between favorable and unfavorable intermediate. Rest are same, 2T, T2B and C, and PSA more than 10, less than 20. Both are same, only grade is different.
I would like to add upon this that the percentage of positive biopsy cores are also an important criteria for that. If they are less than 50%, we keep it in favorable intermediate. But if they are more than 50%, that's placed under unfavorable intermediate.
But that is not mentioned in the NCCN, I think. That is mentioned in NCCN for low risk, very low risk and low risk. But it is not mentioned in the intermediate risk category, I think.
No, in the intermediate risk category also that forms a part of the classification, the prognostic classification.
Anybody else who wants to add?
Apart from this, sir, the latest NCCN guidelines have also introduced molecular testing in this, like Polaris or Oncotype products that further helps in deciding the treatment for these patients. So that is also a compulsory part of the risk stratification now, like the further workup.
We'll keep it for next conference. Next, please. Coming on to high risk.
Okay. High risk will be T3 and PSA more than 20. And Gleason score is 4+4, 8 or grade 4. That is high risk. And it will very high risk will be T3B and PSA is more than 20. But grade is pattern is 5 and more than 50%, I think, grade more than 80%.
We'll keep it high risk. Okay.
Okay.
We'll keep it high risk. So moving on, this is just a brief overview, and then we'll start with our main topic. Next, please.
All other senior residents are also requested to speak. Preet, you can ask question by their name also.
Yes, sir.
कुछ लोग हमारी तरह होते हैं ना, बैक बेंचेस बैठे रहते हैं यार.
ठीक है सर. So now coming on to our main topic, target delineation. So planning CT. I'll like to ask those who are not speaking, as I said, Dr. Vashu, can you tell us about planning CT? How will we start with the planning CT of the prostate?
For planning CT, we would need to follow a comfortably full bladder protocol and empty rectum.
Okay,
protocol.
Comfortably full bladder protocol. What do you do?
Sir, we ask the patient to empty the bladder and then to drink 150 to 200 ml of water.
Okay.
And then we wait till wait for 30 minutes. And then we take a CT scan of 3 mm slice thickness.
Okay.
With IV and oral contrast.
Okay. Anybody else who does a different thing?
Sir, if I may, there are multiple bladder protocols which are followed, sir. And sir, one of the most means commonly followed one is 2 cups of water followed by 30 minutes. The 2 cups of water should be taken within 10 to 15 minutes, and the post 30 minutes of start of taking water will scan the patient. That is one of the most reliable techniques. But otherwise, there is 1 liter of water taken within the first 15 minutes and 45 minutes later scan. Those are also practiced.
But I think 1 liter of water would be quite
too much. Yes, sir. That is true, sir. That is a huge amount, but these are also available in the literature, sir.
Yeah. I am not going into the literature. I am just sticking to what we do. And
yes, sir. 2 cups and 2 cups of water followed by 30 minutes would be a good protocol.
Like in our hospital, we do 4 cups of water, 100 ml each, and we wait for 30 minutes because most of the Indian patients are actually dehydrated. So,
correct,
so that takes time to fill. Anybody else who wants to add? Dr.
To add a point that whatever the protocols we are following, either from literature or institutional policies, we must also individualize these criteria because maximum patients suffer from cystitis, the prostate cancer, and holding such amount of urine may be difficult for patient. And during treatment also, patient may.
Dr. Avradeep, you want to add something?
No, the point that I was making has already been made. Basically, what we follow in our institute is 350 ml of water after voiding of bladder, followed by the CT 1 hour later. The point that I was trying to make was that it has to be individualized from patient to patient, since all of these patients will develop cystitis at some point of the time during the radiotherapy or just beyond. And so the bladder capacity does not remain uniform all throughout the radiotherapy course. So that point has already been made. So
that cystitis will cause frequent urination, and frequent bladder filling, which will not be filled, but this is a common problem what we face.
Exactly.
Okay, moving on.
And regarding simulation planning, sir, oral contrast also we can give 2 hours prior to the scan, and also IV contrast 10 minutes prior to the scan. We also give.
How oral contrast will help?
Small bowel to delineate small bowel. We can give, we cannot give also.
Our contours will be in pelvis only.
Okay. Sometimes a post-operative case, small bowel will be in that area.
We'll come to post-operative thing.
And IV contrast also 10 minutes prior to.
Is fine.
Okay.
So,
sir, if I may add, actually, for planning for the CT simulation, I starts much earlier compared to the bladder protocol, sir. The previous night itself, we should ask the bowel preparation should be started.
And
yes,
patient
sir.
to be, that's the next point which I am coming on. Rectum preparation.
Yes, sir. Sir, rectum, the bowel preparation, which started the prior day. The night, since 8 o'clock to 10 o'clock from night, the patient is asked to have liquids only, and then they are asked to have an enema. And in the morning also they are asked to have a repeat enema, and then this is the entire bowel preparation for protocol that we follow for the patients.
Every day,
don't you think enema giving 2 times, we are giving 2 times enema and following it for a 30 days protocol or a 26 days or 20 days protocol, will it be difficult?
Sir, but if the food intake is controlled, like the night foods are limited, then this can be the rectum filling can be maintained. For daily treatments, the enema is not followed. Enema is not followed on every days. The reason that we are following this enema on the first day is that the patient's diet has not been regularized, which will be regularized after advice once the treatment is started. So we can get a reliable.
Dr. Ankita wants to add something. Dr. Ankita.
Rectal protocol is a very important thing. We have to ensure it at the time of CT simulation because it's very prone to introduce systematic error in the treatment.
Definitely.
So we have to counsel the patient accordingly that you have to pass tools every day before the treatment. And also we have to discuss with the patient the bowel habits. Then accordingly, we have to decide whether we need laxatives or not, because too much of laxatives can also lead to diarrhea. So another thing for rectal protocols are you have the endorectal balloon. They ensure a very good mobilization, and they can also help in reducing the PTV margins.
But that will need you daily. You should fill that balloon, and daily on machine, on treatment couch, you should have a person who will train. I think we SRs and we doctors are there, so we will have to do it daily on that. So
sir, I want to add upon this. Yes, sir, we have tried this in one of the patient for the rectal balloon, but yeah, this is a very difficult procedure because technicians don't do these things. We have to go and do, and that is also painful for patient. Patient many times refuses to do daily rectal balloon insertion. So that's difficult.
It's very difficult to follow daily this laxative or enema. So we just encourage the patient for regular rectum emptying before the treatment, and prescribe the laxative only if the patient is having laxative. And also during the scan, we see the rectal diameter. If it is more than 4 centimeters, we have to rescan again. During the treatment, also same thing. If you find that in CVCT the diameter is more than 4 centimeters, you have to rescan.
Dr. Avradeep.
Yes, 2 points. Number one, I think giving an enema is too much of an extreme step, because it becomes a lot of hassle for the patient to get an enema in its home setup. So until and unless the patient is admitted, an enema is a bit of a hassle. What enema does, that can easily be achieved if we can start the bowel preparation at least 3 to 4 days before the planning CT rather than just before the night of the planning CT. That takes care of even the chronically constipated patients and not the patient just who is passing bowels regularly. That is point number 1. Point number 2 is, although I understand the laxative is a bit of a double-edged sword, but for our patients, what we see is these patients are chronically constipated, and to maintain, and the prostate fields are also not that large that they do cause a lot of GI toxicity in the short term. What GI toxicity we have is in the long term. So we do not get any acute GI toxicity as such. So we have been able to continue some amount of laxatives for these patients and being able to maintain adequate levels of bowel preparation all throughout the treatment by continuing laxatives all throughout the treatment. Not very high amounts, but moderate amounts.
So what we can summarize is that we should prepare, bowel preparation should be done 2 days earlier, and that should be given with a mild laxative, and a rectal diameter should be fixed so that it can be taken up. Ke isse zyada hoga to we will not take the CT and will. Okay, so we all agree on this. Now come next, please. So, and what about the CT? 4D CT or 3D CT?
We do not.
So, sir, 4D CT is one of the best option for the prostate cancer. Not only prostate cancer, all the cancers where there is a movement. So 4D CT is considered superior, but obviously many centers don't have this, especially the government center don't have facility of the 4D CT. So if we don't have that, then we can do the slow scan CT, 3D CT, slow CT, 3D CT.
Actually, sir, I would like to intervene now. The thing is, 4D CT is useful when we have a regular movement that we are expecting, like breathing movements or something. When we are not expecting a regular movement, then 4D CT may not be that useful as expected.
I would, okay, same thing also. 4D CT is helpful when there is an organ motion during the treatment. It will not be that helpful if there is a change in position of rectum or bladder, that is more in interfraction change in position. So 4D CT will not be that helpful in these patients. Normal 3D CT will be scan we are doing actually.
Yeah, Dr. Avradeep, you wanted to add?
Yes, we do have a 4D CT, but still we prefer to go with the normal CT because with the regular IGRT, if we are having a regular IGRT setup, then even with that, we have seen the shifts are minimal with the kind of PTV margins that we have. So in our setup, we do not practice a 4D CT, even though we have the option for it.
Yeah, Dr. Ankita, please.
Our institute, we are also not practicing 4D CT. What we do is gold seat placement and CBCT that allows online correction. So we are finding minimal setup errors. So we don't also think that 4D CT is required in such cases.
So we all agree on not doing 4D CT for a high risk prostate cancer, T2 more than T2 disease, where it will not be any helpful with adequate bladder and rectal preparation. Okay. So
Yes,
coming on next, marker placement.
Yes, sir. Marker placement is another important issue that she has brought up, rightfully brought up. Marker placement should be placed almost 5 days prior to the scan. And this 5 days is for the edema to subside so that we get a more representative scan during our CT simulation. So marker placement, although not widely practiced, is a good way for IGRT when we are thinking of IGRT.
Dr. Ajay Krishnan, I would like to interrupt. Would you please say whatever you practice? I mean, whatever is written in the literature is as something different. What do you actually practice is something we want to know, because we are sharing a common platform here and we would like to know what actually is being done across the country.
Yes. At my institute, use markers.
Dr. Ajay, just very curious question. If we are doing a 3D CRT, do you need marker placement?
Sir, 3D CRT, for 3D CRT, we do not need a marker placement, but IMRT is usually preferred in prostate cases because of the high dose that we are going to give to the local site and the presence of penile bulb and rectum very close to the lesion. So IMRT is usually preferred in these cases. That's why, and it is known that the matching, IGRT matching based on bony landmarks is not as as good as having a gold marker which is present within the tumor field. So that is why gold markers may be better technically compared to IGRT using bone matching.
Okay, Doctor.
In our center,
Dr. I'll come to you.
Okay.
The point I want to make here is if we are practicing daily IGRT with a KV CBCT that most of the machines that we have right now are capable of, then I think gold fiducials is a bit of a hassle, as well as it is an extremely costly affair. But most of the modern machines come with a KV CBCT which can be used daily if the patient load is not too much. And I think that gives extremely favorable results. What if the machine that if the LINAC that we are using does have only an EPID or something like that and not a CBCT, then maybe if we are having the option of gold fiducials, that may be an advantage. But with KV CBCT, I think if we look at the cost benefit analysis and everything with the patient comfort and everything, I think KV CBCT daily is a better option than a gold fiducial.
Okay, Soumitra, you wanted to add.
We do not use gold fiducial for normal IMRT patient. We treat with the image guidance CBCT, and we do not match the bony. It's better to match the prostate itself. Thereby, the error will be less, and normal IMRT patient will do the treatment with image guidance with the CBCT matching with the prostate. Gold fiducial we use for the SBRT patient only. We do not use normally gold fiducials.
Dr. Vashu, do you want to add something?
Sir, in our institute, we are using both the techniques. One is the gold fiducial placement, and another is that we are taking is on treatment table. We are using the clarity probe to track the real-time tumor location.
Okay. So we are all on the page. Dr. Ankita wanted to add something.
At our institute, we are using both the modalities, gold slit placements as well as the CBCT. What we have observed is that as per the literature also, that CT has limited sensitivity in prostate cancers. So obviously there are some areas of discrepancy like its interface with rectum. So we are not very confident when we are only using CBCTs. While gold seed placements is a very small marker, like it has a maximum dimension of around 3 mm. So when we are using gold seed placement and online correction, so it gives a very precise idea of the target matching. So we are more confident with gold seeds as compared to CBCT.
So what I can gather is that if we are treating prostate with nodal irradiation, we don't need gold seed marker placement. And if you are doing a SBRT and very precise high dose treatment to the prostate, we need gold seed marker. Okay, next please. Next slide, please.
Dr. Ankita want to add something.
Yes, sir. I only wanted to add the conclusion what Dr. Purohit had said. That we in our department we don't have a CBCT facility, and as a government setup, the patients are very poor. They can't. We have to use 3 gold seeds, fiducials, and that is a very costly thing. So we don't prefer gold fiducials in our patients, and it has also only beneficial when we have to treat only the prostate, not when we have to treat the lymph node area also. That's not a very beneficial thing, and there are very few patients in which require only prostate only radiotherapy. So prostate, I think
and that too very high dose, precisely to the prostate, very high dose per fraction.
Yes, sir.
Yeah.
All other senior residents, please participate. Otherwise, certificate will also get cancelled.
Next, please.
Mark, yes, sir. Can I? Okay.
So we'll move on to contouring. Contouring for prostate. Next, please. So delineation of prostate. How will we start? Ankita, Dr. Ankita, please.
So for delineation of prostate cancer, we have to keep in mind that we have to use both the modalities, a CT scan as well as MRI. MRI offers several advantages. First of all, the areas of extraprostatic extension, the area of seminal vesicles, the neurovascular abundance, and the anterior fibromuscular stroma. These are the areas that cannot be well identified. So we need to have an MRI always. It improves the accuracy. And secondly, also the penile bulb and urogenital diaphragm are well discernible on MRI. So we always incorporate a MRI in this.
Anybody wants to add?
And I would like to add the delineation part, sir. Like in this, GTV is the entire prostate. We a particular part of the GTV.
We'll come to it. We'll come to it.
I'd like to add that the MRI must be done in the same bladder and rectal protocol and with the same treatment positions.
Planning position. Same MRI should be done in a planning position. Yeah.
Puneet, why don't you ask question directly to other senior residents who are not participating?
सर जितनों का नाम मैंने टिक किए हैं सबसे बात कर रहा हूँ सर.
अच्छा ठीक.
Sir, I want to add that yes, the point is noted that we have to use MRI in the same simulation position as like that of CT. But what the problem many times we face is more of the rectal protocol. That when if ever there is a gaseous distension to the rectum, then that hinders the problem because on the same day we are not doing MRI and the CT scan.
Yeah,
so that we can maintain the bladder protocol, but not the rectal protocol. That is the main thing we have to take into account.
That's very genuine and common problem. But what can be done is planning CT can be done on the day of MRI, basically. That we can do. Yeah, Dr. Avardeep, you wanted to add.
Yes, the only point I was making is that an MRI is always preferable because of the reasons that have been already mentioned. But even if an MRI is not available at present when we are contouring or when we are about to treat the patient, I think we can at least go ahead with the treatment with the CT that we have, with the planning CT that we have, and not actually delay the treatment just because we don't have an MRI. Because in a government setup, very practical problems, most of our patients, they forget the CT, they forget to bring the MRI, they get the CD is lost. All these things keep on happening. So in a high volume center, rather than delay the treatment, even if you don't have an MRI, I think it's a better option to go ahead with the treatment rather than wait for an MRI. Or although prostate is a extremely low growing tumor and you can do that, but yeah, I think it's a better option.
But MRI should be done.
Yes, of course.
These are logistic problems, but MRI should be done.
Yes, an MRI is a must, but even if it's not there, the treatment should not be a no-go.
Yeah. Anybody want to add?
Yes, that is a very genuine problem which has been addressed, that in a government setup with their high volume centers, we don't get dates for the MRI for the patient to do in the same day, unlikely the private center. And also I want to add that the CT thickness should be of 2.5 mm compared to 3 mm when we are using it with the MRI. And that fiducial marker should be placed at the anal verge.
Yeah, slice thickness we are using is 2 mm for contouring prostate actually.
Okay.
And 2 scan.
Actually, when you are contouring prostate, then it should be 1 mm, only prostate. If you want to add nodal also, then you can use 2.5 mm or 2 mm or 3 mm, whatever your physicist likes to use, that you can use. So next, please. So anybody who wants to use PSMA PET CT?
We have the PSMA facility here. We used to use the PSMA, but it's not recommended, or it has not come into the guideline. There may be some issue for the fusion of the PSMA, same treatment position and everything. If we are using giving boost to the dominant nodal, then PSMA PET or multiparametric MRI may be needed. Just MRI.
3D CRT, I am
just MRI is good. Just MRI is good enough. Just MRI is good enough. T2 wetted image is
Dr. Ankita Mehta wants to add.
Yes. PSMA PET has a rule when we are going for salvage radiotherapy. Then we have to accurately identify the intraprostatic lesion for boost. But if you are planning for the first time, I think MRI will suffice and is more sensitive in planning cases.
Okay. So, Dr. Avradeep?
The only time that we use a PSMA PET guidance is when we are not sure if nodal involvement. If there is a suspicious node, but it's not meeting the other criteria for a malignant node, and we are not sure, that those are the only places that we in our center take help of our colleagues from the PET center to find out if that node is malignant or not, or should we treat it or not. Otherwise, for prostate, we are not using it as a routine.
Okay. Dr. Afroz, are you there?
Yes, sir.
Yeah, you want to add something?
Sir, I'll agree that basically we go with an MRI because for the lesions which are residual or after some after the treatment, then we'll go with the PET fusion to identify the lesion.
Okay. And Dr. Vashu, will you want to add something?
We do MRI fusion.
MRI fusion.
Yes.
So I want to ask all the participants that for contouring for prostate only, will PSMA add any information?
No.
No, PSA does not add any
No, sir.
information. MRI is sufficient.
MRI, sir. Chalo, we'll move
MRI,
to
sir.
the next thing. Next, please. So, what margins will you take for contouring prostate? And now I am only for the prostate and prostate margins. Yeah, Dr. Ankita.
For
Margins, that depends on our immobilization systems and the institutional protocols. But if we have a good immobilization system, we are using IGRT or CBCT, we have the daily matching with online correction, we can reduce the margins up to 3 to 5 mm. But obviously, if we don't have a image guidance, we have to take higher margins of up to 1 centimeter. And in some guidance,
What you practice? You
at our institute, we are treating with the protocol of 7 mm margin.
okay, 7 mm all around the prostate.
Yeah, 7 mm all around the prostate.
Okay.
okay, sir, before coming to the PTV margin, one has to take account of the extraprostatic extension, the potential that margin, potential margin for extraprostatic extension. For intermediate risk, we have to give a 3 to 5 mm margin, and excluding the rectum, and superiorly also 0 margin. And for high risk also, we have to give a margin of 5 mm all around, and not in superior direction, and excluding the rectum also. This is has to be taken in the CTV margin. Then we'll come to the PTV margin. And PTV margin depends on many factors. One of the is institutional factor. What is the
that we know? It
okay,
depends on
okay.
many factors, but
And
what
second
you
thing,
practice?
we practice with CBCT. With CBCT, we give daily CBCT 6 mm all around margin.
Okay.
And if we are not practicing the CBCT, then we give 8 mm margin all around and 6 mm margin towards the rectum posteriorly.
Okay. So, Dr. Ajay?
Sir, the same here, sir. Right, like it is rightly pointed out, the 3 mm margin around the whole prostate and seminal vesicle contoured should be given in case of IR and HR cases. And in after that, a PTV margin of 5 mm is usually given at our institute, since we are going ahead with the daily imaging. That's what we follow, sir.
Okay. Dr. Ankita?
Yes, we use mainly 7 mm margin around the prostate, and we give a larger margin around the seminal vesicle, taking account that the movement of seminal vesicle is internal motion is more as compared to that of the prostate. And yes, it depends upon the radiotherapy, various radiotherapy techniques. And if we are using daily IGRT, of course, we can reduce the margin to 3 to 5 mm.
Okay. Dr. Vashu?
We are using again 5 to 7 millimeters of margin, but for posteriorly for rectum, we are taking up to 3 to 5 mm of posterior margin.
That you take for CTV to PTV.
That we give to PTV.
Yeah, CTV to PTV.
CTV to PTV, yes, sir.
Yeah. So, Dr. Avradeep?
We take a PTV margin of 5 mm.
5 mm. Okay. Dr. Afroz?
Basically, CTV includes the entire prostate plus minus seminal vesicle, and for the PTV, if CTV plus 1 centimeter in all the directions except 6 mm, which is in the posterior border.
Okay. So we all agree with shorter margins, 6 mm all around, and 3 mm from the rectum side, with daily bladder protocol, daily rectal preparation, what we do, and daily CBCTs. So we agree upon this.
Yes,
Okay.
sir.
Next, please.
Sir, Dr. Abdul Wahid Dar, Dr. Naveen Kumar, and Rahul Sharma has also joined, sir.
Okay. Dr.
Also, Dr. Garima,
Dr. Abdul Wahid Dar,
Dr. Naveen Kumar,
Dr. Rahul Sharma, and
Dr. Garima.
Okay. Thank you. So next, coming on to nodal irradiation. So lymph node patients to be included, intermediate risk, high risk, very high risk. Go on, Dr. Ankita Mehta.
For low risk and very
No, I have intermediate risk, high risk, and very high risk.
nodal, there is Roche formula and Perkins tables. According to that, we calculate the estimated risk of nodal involvement. So if it's more than 15%, we go for nodal irradiation, sir. And as
Okay.
unfavorable, intermediate, high risk, and very high risk cases are offered nodal irradiation. And, sir, and the stations included are, we include the distal common iliac that are below the L5S1 junction, the
Okay.
external internal iliac, the obturator, and the presacral group of lymph nodes. These are the target nodal stations, sir.
Okay. Soumitra wants to add.
According to this new energy guideline, this common iliac node, it should be started from bifurcation of the common iliac, outer to common iliac.
Proximal common iliac also.
Proximal common iliac and presacral group up to the S3. It will be taken up to the S3 lower border. This is the order. And we treat only high risk patient, high risk and nodal positive patient. Only we treat nodal groups. Otherwise, in low risk, intermediate risk, we do not treat because there is no so much evidence for RT to lymph node. So only high risk and lymph node positive.
It's a slightly gray zone, but high risk and very high risk should be treated. So anybody wants to add something?
Yes, sir. We use nodal we do nodal irradiation in the patient of unfavorable intermediate risk and high risk patient, and that's according to the Roche formula, and also according to the one of the Partin table which we use. And if the risk is high, we generally include the nodal stations from the common iliac, internal, and the obturator and presacral.
Okay. So all of us agree on this?
Yes.
Okay. Next, please. So the lymph node station you mentioned, how to contour, starting with Dr. Vasu.
Start with contouring the vessels, and we contour the abdominal aorta. We contour it up to the bifurcation to the common iliacs, and then to the external and internal iliacs, and then we give a 0.7 millimeters margin to these vessels. For the lateral external iliac group, for the obturator group, we also use a 1.8 centimeter brush to join the external and the internal iliacs. And for the presacral nodes, we use a brush of 1 centimeter to cover the presacral. So starting from S2, S3 levels.
Yeah, up to S2, S3 level, starting from the bifurcation, the presacral area. Yeah, Soumitra.
For presacral, we use a diameter of 1.2 centimeter that covers more area, 1.2 centimeter.
Okay. Use. Dr. Abdul, you have joined late.
Yeah, sorry, I was busy with patients. So far as nodal contouring, in our setup, we use an intermediate as well as high risk for common iliac.
Okay.
Because our patients present with the T3, T3A, T3B, late presentation, not than T1 and T2. So we preferably intermediate and high risk use from common iliac, because sometimes common iliac are contaminated with microscopic disease.
So
no doubt there.
You start with aortic bifurcation. You include proximal common iliac also. So
Sure, sir.
Contour them.
Yes. And so far as MRI is concerned,
no, I'm not talking about. I'm not talking about MRI. I'm talking about how you contour the common iliacs. You start with contouring the vessels and then giving margins
Absolutely, sir.
around it.
Absolutely, sir.
Yeah.
With vessels, and then give the 7 mm margin.
Okay.
That is enough for us, sir.
Okay.
And testicular area is something 1 to 1.5. It varies.
Yeah. Pre-sacral, Soumitra said he uses 1.2 and mentions it's 1 to 1.5.
Yeah, because of benefit of doubt, our patients are somehow, because the MRI as well as CT plan is not exact what we achieve. So there is a variation.
Most of the time we don't do the MRI in the planning position.
Yes, sir. Yes, sir. Yes, sir.
Yeah, Soumitra, you wanted to add?
For external iliac lymph node, margin is 7 mm, but anterolaterally it will be 10 mm margin.
10 mm margin.
And up to lower level will be the external iliac just goes out of the pelvis or goes into the inguinal ligament or inguinal canal. That is the lower limit of external iliac.
Okay. Avradeep?
Just 2 points. We do not practice that anteriorly 1 centimeter margin. For us, we do practice a 7 mm margin all around, and it remains that way. And the other point is for joining the external and the internal iliac, we use a 1.7 mm brush, which is, I think, a bit different from the other institutes.
No, it's only 1.6 to 1.8. Some practice 1.6, some practice 1.7, 1.8. It's not. It hardly makes a very much difference. So next.
Sir, I want to add that when we don't usually start contouring from the bifurcation of the aorta. The reason being that if we start from the bifurcation of aorta, then after that, when we give the PTV margin, again the area increases. So we generally don't use that.
It goes up to L3.
Yes.
Yeah, Dr. Ankita Mehta.
Yeah, so for external iliac, if there is no gross involved node, we take a margin of only 7 mm. But
yeah, most of the centers do this. Gross
node. Then we increase the margin of up to 10 mm. So that's what we are practicing, sir.
Okay. Dr. Avradeep?
Just 1 point. Even if we take it, we actually take from the bifurcation of aorta. And the kind of for the prostate, whatever radiotherapy any center practices, I think the laws are very stringent with extremely stringent bladder and rectal protocols, daily IGRT and everything. I think the toxicities are extremely minimal, even if we transgress the margins by 1 or 2 centimeters superiorly.
Yeah, but if you practice a 2D, you will place your upper border at L5S1 junction. That covers most of the external iliac, if you will see it.
Sir, I would like to bring this up for discussion too. Whether common iliacs are routinely included always, like.
It is in our
distal common iliacs are included. What I have read, and most of the centers do it.
Okay, sir. Because at our center we take external and internal iliac, the L5S1 roughly as the upper border.
Okay. Dr. Afroz? Okay, next we'll move next. Next, please. So, elective or prophylactic nodal irradiation. Intermediate risk, there is a gray zone. We all discussed. High risk, we want to give nodal irradiation. Yeah.
We prefer going with an elective nodal irradiation because most of our patients, unlike their Western counterparts, are not very comfortable with the idea of regular follow-ups or regular anything. So we are on the side of caution and over-treat rather than have a patient which we under-treat and then the patient lands up with us with huge pelvic lymph nodes maybe 1 year later.
Yeah, that's the thinking of us studying in the most of the government centers, that we should over-treat because patient is not going to follow up to us. Okay. So anybody wants to add?
Yes, sir. Actually, I would like to say the same, sir. What we follow here is that for the intermediate risk, we take the Roche's formula, and if it is more than 15%, we used to treat intermediate. Otherwise, high risk and very high risk are routinely treated, especially because our patients might not follow up and might turn up with recurrence later.
That's the main issue.
Yes,
that
sir.
Patient follow-up is not there, and once patient is gone, You can't do if a node comes and you have given radiotherapy. So that's a common problem. But in private setup, it has to be something else. So Dr. Ankita?
So we are offering prophylactic radiation only to patients who have an estimated risk of involvement more than 15% or only beyond unfavorable intermediate risk patients, sir. Below that, we are not offering nodal irradiation, sir.
Yeah.
And the landmark RTOG 9413 trial was there that specifically addressed this question that prostate only RT or whole pelvic RT, they demonstrated a clear advantage with whole pelvic RT. So I think that should be practiced in unfavorable intermediate risk patients, but there are also a lot of controversies revolving around this.
So we are on the same page that Roche formula, if it is more than 15%, we'll go for elective nodal irradiation, and in high risk, we all do it. Okay, next please. Nodal margins we have discussed. Next please. Coming on to dose. Next please. So dose to the prostate in low risk. Okay, start with Dr. Ankita Mehta.
Sir, in low risk, the dose is 75.6 to 79.2 gray, sir, at the rate of 1.8 gray per fraction.
In how many fractions?
So we are going up to 33 fractions, sir.
72.9.
No, so 79.2, 75.2.
Sorry.
We are treating over a period of 7 weeks, sir, at a rate of 1.8 gray per fraction.
Okay. Avandeep?
Actually, I have not seen a single low risk patient in my setup yet. So I really don't know what kind of dose we'll prescribe if we ever find one. All our intermediate and high risk patients, we earlier used to treat up to 74 gray. But now recently we changed our practice. We are actually treating by the chip protocol. So
60-20.
16-20.
Okay. Soumitra?
In our setup, low risk, if we are treating conventionally fractionation, we do 79.2 in 44 or 80 gray in 40 fraction. And also a lot of patients we are treating hyperfraction, cheap trial, 60 gray in 20 fraction, low risk patient and moderate risk patient.
You are doing conventional fractionation till now.
We are treating hypofraction also. Many patients we are treating hypofraction, low risk.
Dr. Ajay?
Sir, actually, what the same, sir. Actually, we don't treat low risk patients, sir. So we treat high intermediate and the high risk patient. So we do take the patient's general condition into account, and mostly more than 50% of the time we give a conventional fractionation, the 78 gray in, at a 2 gray per fraction, and occasional patients we have also, and when the logistics issues also are taken into consideration, we have also given hyperfractionation, and not the chip protocol. We go with 17-28 fractions.
17-28, 2.5 gray per fraction.
Yes, sir.
Okay.
So we have also used hypofractionated regimen in our center of 60
I'll come to hypofractionation. Don't worry.
Yes, sir. And mostly in low risk patients we follow brachytherapy.
Okay.
As a monotherapy.
Okay, so we don't have low risk patients, so we'll move to intermediate risk. Next, please. Intermediate risk. Dr. Abdul, dose for intermediate risk.
Sir, in our setup, very few patients I have seen in my life low risks, and unfortunately, they all are operated. So we don't need to treat such patients.
Intermediate. I am asking you intermediate risk.
Yes, sir. In our setup, intermediate high risk patients, we used to give 80 grays in conventional fraction 1.8 grays.
Okay, nodal irradiation dose you will be giving?
Yes, sir. We used to 50 to 54, sir.
Okay. So, Soumitra.
For nodal irradiation, we gave 46 gray 23 fraction, 2 gray per fraction.
Okay. And any difference in high risk, intermediate risk, nodal irradiation dose?
No, dose doesn't change risk according to risk. High risk, same dose nodal irradiation. We do not boost the involved node. If there is involved node, we are not boosting it. Actually, it's very difficult to reach that dose and also constant, achieve those constant, bowel constant and bladder constant. We are not boosting the nodes.
So I'll come back to you. 1 minute. Next, please. So high risk, we all have discussed that nodal irradiation, 46 gray, 50 gray, and then followed by conventional fractionation, 80 gray to the prostate, 78 to 80 gray. So now I'll come to next, please, N+ disease. If there are positive nodes, who wants to boost? Dr. Ankita.
If there are positive nodes, it's actually a gray area. As the NCCN say that in this case, these patients may be kept on ADT alone as well. But there are two options. Either we can
but you are giving radiotherapy.
So if we are giving radiotherapy, we prefer to boost the involved node.
Okay, how much dose?
So we are going up to a dose of 68 gray if the node is involved, sir.
8 gray to the nodes. Okay, that's new. Anybody wants to add?
I think after the POP-RT trial, I think that controversy has been put to rest, that leaving the nodes aside for ADT to take care of it. Okay. For the nodal disease, we try to give as much as dose as possible. I'm not really sure. I think we go up to 55, but I'm really not sure, because recently, whatever patients we have had after shifting to the chip regimen, they were mostly node negative. So I have personally not been involved in the planning of a node positive patient who has been treated by the chip regimen. So I am not sure about what.
Sir, we also generally don't practice to give the boost to the nodal positive nodes. We really restrict it to the up to 45 to 50 gray only, not more than that, because again it will add up to the toxicity.
Okay, Dr. Afroz.
The same, because there's not much concept of giving a high dose to the node, not more than 60 gray.
Okay. And Dr. Ajay, you want to add something? He has gone somewhere. Dr. Varshu?
Sir, again, we have gone maximum up to 60 gray for nodes, but not beyond that. And mostly patients are put on ADT after this.
Dr.
Sir, actually, we also haven't treated a not positive patient. So, means my best case would be we should be going up to 60 gray, because we have boosted pelvis other diseases up to 60 gray. So 60 gray should be safe, sir.
Yeah, I'm not also sure, but 54 to 60 gray is the reasonable dose for nodes to be positive if they are. And so.
Because in cervix cases, we have, when there is a node positive case, we do give boost up to 60 gray. So 60 gray should be safe.
60 gray should be safe.
Actually, when we were practicing the standard fractionation, we were treating the nodal irradiating prophylactically up to 45 gray. And if there were positive nodes, we were we are boosting it to 55 by SIB. And then we are giving the rest of the EF up to 74 gray. So I'm not sure what the current regimen is after we have shifted to hypofraction.
So we are all on the same page that N+ disease, we'll read how much dose we should give. So next, please. Next is that we have discussed prophylactic nodal irradiation. And next, please. Next is hypofractionation. So whatever you practice.
We practice mainly 60 gray in 20 fraction, hypofractionated schedule. None other schedules are practiced.
We practice the cheap protocol, that is low risk of seminal vesicle involvement less than 15% by Roche formula, and moderate risk less than 30%. And we give the 60 gray 20 fraction. There will be 3 volumes: 60 gray, 57.6, and 48 gray. Only prostate, no nodal irradiation. And the contouring is, as per the protocol, it is little bit different from the usual contouring. And constant also different. We practice that 60 gray in 20 fraction.
Okay. With daily bladder protocol?
Yes, CBCB, daily, daily CBCT.
Okay. Any other hyperfractionation protocol we follow?
Yes, yes. Actually for adjuvant treatment, post-operative 52.5 in 20 fraction we practice, and for old patient and some that poor performance status, that 57 gray is also we practice. That is one study that beneficial against 60 gray in for poor performance status and more than elderly patient. That also we practice. And basically hyperfraction, this is 60 gray and 20 fraction, and adjuvant is 52.5 in 20 fraction.
Anybody wants to add?
At our institute, we follow 70 gray in 28 fractions, sir.
Okay, 2.5.
Yes, sir.
Okay. Anybody who wants to add? नहीं तो सर का मैसेज आ गया. Dr. Ankita Mehta.
Hyperfractionation we are not routinely using because generally we are going for whole pelvic radiotherapy as the estimated risk of nodal involvement is higher. So those patients are not the ideal candidates for that because of the toxicity concerns. So most of the patients we prefer to treat by conventional schedule.
Okay, 80 gray, 40 fractions.
Yes,
okay. Okay, thank you all for participating. And next, please.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you all.
Thank you,
Thank
judges.
you all. Thank you. Thank you. We will convey the results soon
Thank
to
you,
the
sir.
organizers. Thank you. All of you participated really well.
Madam, you can make Madam, you can make a comment on the panel discussion, and Dr. Neeraj Rastogi also.
Yeah, actually, I would really like to thank everyone for participating. What we could actually see is some of you were really active in participating than others, and I would talk to Dr. Neeraj Rastogi once, and we will convey the result to the organizers. Thank you, Dr. Nagpal, for coordinating and moderating the session so well. Thank you so much. It was a great learning experience. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you.
Okay. Yeah. Right. So, Dr. Anil, the case for you is over here. A 60-year-old male was found to have a PSA of 5 after having a test in a routine screening camp. So, the patient was asymptomatic. The digital rectal examination was benign. There was no nodule or anything felt. However, they went ahead with a biopsy. And after doing a biopsy, the Gleason was 3+3 in 1 out of 5 cores of 1% on the left side. Right side was totally benign. MRI, there was no visible lesion seen. The bone scan was totally normal. So this is your 3 questions. The first will be, what are your treatment options? So your time starts now. So how are you going to treat this patient as an oncologist? Dr. Anil? Okay. So Dr. Aditi? Dr. Aditi, you are also not there? Dr. Afreen? Yeah, Dr. Afreen, have you heard the question? I'll repeat it for you. A 60-year-old man, he just did the routine PSA in a screening camp, was found to have a PSA of 5. So they did a digital rectal examination. It was benign. They went ahead with the biopsy. Gleason was 3+3. And in 1 out of 5 cores, 1% on the left, right side was benign. MRI, there was no visible lesion. Bone scan was normal. So what are your treatment options? You can simply start with, what is the risk stratification of this case? What are the treatment options in this risk stratification? And then go on to the other 2 questions.
Thank you.
Your voice is breaking actually, Dr. Afreen.
You can take another candidate. No? You can take Dr. Akash Pandey. He is available. Dr. Akash?
Okay, fair enough. Dr. Akash, yeah, you can come. You here, Dr. Akash?
Yes, sir. Yes, sir.
Yeah. So you must have heard the question.
Yes, sir, I have. this patient can be stratified into a very low risk category, provided the PSA density is less than 0.15
Right.
nanograms.
So just
per
as an
ml.
oncologist, first of all, you tell me what is the stage, what is the basically the risk staging?
Sir, this is a T1C tumor, clinically non-apparent tumor.
Hello.
And the only recent grade group 1, 3+3, 6, and 1 out of 5 core positive. So it is very low risk disease, sir.
Go ahead with another questions that describe the treatment.
Okay. So what will you do with this? What
Sir,
is your
for
treatment
this
option?
patient, the treatment options would be active surveillance, or if the patient, because the life expectancy of this patient can be considered to more than 20 years, since given that he does not have
Fair
any
enough. You
comorbidities.
told me one active surveillance. Any other treatment options you would like to consider?
Sir, another treatment option is radiotherapy in form of external RT alone, or
Active
in
surveillance
combination
is
with
the best one. Fair enough. Agreed with you. Then other options?
surgery, sir, radical prostatectomy.
Okay. Okay. Right. Now, let's say you go in for external beam RT, radiation for this patient. Okay. You counsel the patient for active surveillance. He doesn't agree. You go for radiation, EBRT, plain EBRT. What will be your treatment volumes? What will be the dose prescription?
Sir, for this patient, the treatment volume would be whole prostate, and the seminal vesicles would be considered as the CTV, and would be given a margin of 5 mm to 1 centimeter depending on the institutional protocol. The dose prescription would be 78 grays to 80 grays at 2 gray per fraction if we are going for conventional treatment, sir. Or if you want hypofractionation, we can even treat it with 60 grays in 20 fraction at 3 grays per fraction, sir.
Okay. And describe the daily treatment of this patient. How are you going to treat this patient daily? Any protocols you follow?
Sir, for this patient, both bladder and bowel management protocol have to be followed. The patient has to take soft diet, and ideally the rectum should be empty before the treatment. If it is not so, we can even give enema. For bladder preparation, the patient should be given 500 ml of water 30 minutes before the simulation as well as the treatment. So in this way, we have to ensure that the rectum is empty and the bladder is comfortably full, and preferably at the similar volumes every day as simulation and during the treatment. And for this patient during treatment, sir, we have to do image guided radiotherapy, and daily CBCT has to be taken.
Good, fair enough. Dr. Rajesh, would you like to ask any questions? Sir?
No, I think my only thing is that what is the method for classification of what are the system for classification of the risk, basically the risk grouping of prostate?
I'm sorry, sir, I couldn't hear you, sir.
What are the systems for risk grouping classification in prostate cancer?
Sorry, sir, can you repeat it? I cannot hear your voice, sir.
Don't worry, Rahul, please go to second candidate.
Okay, okay, fair enough. So who is the second candidate here? Now, Dr. Afreen, are you there? Is your audio video all working now? Whomsoever is there, just shout out your name. I'll go to you then.
Sir, Saurabh here.
Saurabh is here? Okay, so
Yes,
we are
sir.
going to Dr. Saurabh. Rajesh sir, please note. Dr. Saurabh, candidate number. Okay, this was the justification.
Saurabh is candidate number.
So candidate number, it's written 7, but actually it will be candidate number 8.
Rajesh, forget about candidate number. You note down his name and assess.
Okay.
Saurabh Karnawat. Okay.
Dr. Saurabh, right? Okay. So Saurabh, here's your case. He is a 60-year-old fit and well man, and he presents with severe lower urinary tract symptoms. The IPSS score is 30 out of 35. The PSA is 12. The DRE, that is digital rectal examination, and as well as MRI, confirms it to be a T2 lesion. The Gleason score is 3 plus 4 in 3 out of 5 cores, 40% on the right, 3 plus 4, 2 out of 5 cores, 50% on the left. The metastatic workup is negative. Now, my questions to you. First one, how soon after TURP, that is transurethral resection of prostate, can you get an MRI done? A very specific question, I need a specific answer.
So we'll wait for at least 21 days.
21 days or maybe a little more, probably? Can you give me a range?
3 to 4 weeks. We'll wait for 3 to 4 weeks, 21 to 28 days.
Okay, fair enough. We would accept probably 4 to 6 weeks. Okay, fair enough. What are the treatment options for this particular patient?
Sir, can you show me the question once again, sir?
Fair enough. Here is your patient. 60-year-old gentleman, severe lower urinary tract symptoms, PSA 12, T2, both on MRI as well as digital rectal, Gleason score 3+4, both on left and right, metastatic workup, negative.
Okay,
No nodes involved.
since the metastatic workup is negative and the Gleason score is of around is 3+4, that is 7. So the patient can be classified into intermediate category.
Okay.
And we can plan for image guided radiotherapy, sir. EBRT by image guided radiotherapy. And after the
Dr. Saurav, I missed your first answer. There was a phone call.
Pardon?
Repeat the first answer. How soon after TURP? You just sir, he told 3 to 4. He told 3 to 4 weeks.
Okay. Okay. Please go ahead.
Yes, sir. Now tell me, what are the treatment options you were telling about EBRT, right? Now continue on that. What were you using?
Sir, since this is Gleason 7, sir, 3+4 Gleason score of 7, and PSA of more than 10, sir, he can be classified under intermediate category. And for intermediate category, we can go for either surgery or we can go for surgery followed by radiotherapy, or else radiotherapy alone, sir, by EBRT by IGRT technique, sir.
Why are you saying surgery followed by radiation? I mean, how do you know that surgery will need to be followed by radiation?
No, sir, that depends, sir. So we can give the option, sir, to the patient, sir.
Okay, one small question. I told you that read the very first line of the question. Would that change your management? He has severe lower urinary tract symptoms.
Yes, sir.
So which out of the two options would you prefer?
Sir, I'll go with EBRT, sir.
Still EBRT? Okay, fair enough. Now, what are your treatment volumes and what is your dose prescription? If you are treating the EBRT, how are you going to treat?
Okay, sir. Sir, we'll check for the nodal status on the MRI also, sir. Are the nodes also
negative? Yeah, nodes are negative.
Okay, sir. Okay. Sir, in that case, we'll include the prostate and the seminal vesicle along with the bulb. Like we'll be including the whole of seminal vesicle, sir.
Okay, and you will not treat the nodes.
No, if they are negative, sir, we don't treat it, sir.
Okay, fair enough. No problem. And what is the dose fractionation you talked about?
Sir, we can go up to 78 grays, sir.
Okay.
Minimum of 74 grays we have to go. Sir, minimum 74 grays we have to go. But there are certain studies which prove that 78 grays are longer period-free survival, sir.
Let us be specific. This is your patient. I am sitting in front of you. I am your patient. You tell me how much.
I prefer 78 grays.
78 gray. Fair enough. How many dose per fraction? Meaning, just tell the entire thing.
39 fractions and 78 grays. 2 gray per fraction.
So 4 minutes over.
Okay, fair enough. Right. So just a little bit of clarifications. This is now your thing is over, but this my personal opinion in this case was this: since the patient was having lower urinary tract symptoms, surgery would be a more ideal option because you could have relieved it. It's not wrong to do anything, but this is just what I had thought on this. And dose fractionation, I believe, okay, fine, you can go ahead with conventional fractionation, no problem with that. Okay, right. So who is the next candidate, please? Please shout out your name.
Dr. Pallavi Kalbande.
Yeah, I'm here. You can.
Okay, fair enough. So Dr. Pallavi, here is your case, your patient, a 70-year-old man. He comes, he basically presents with a PSA of 40. He has got a routine screening done and he has a PSA of 40. However, when the MRI is done, the staging is T3B. Okay. Now they go ahead with a biopsy, and the biopsy shows Gleason score 4+4, in 5 out of 5 cores, 90% PNI on the right side. And on the other one, it is 4 plus 5 on the left. Okay. So this is your patient, 70-year-old gentleman, PSA 40, Gleason 4 plus 5, T3B. Which investigation would you prefer for metastatic workup and why?
This patient I will categorize first as a high-risk patient because of PSA 20. Then for metastatic workup, I would like to go with the bone scan, as bone is the first and the most common site of metastasis. Then my line of management.
No, wait. Just a minute. So we have got an MRI done. You will get a bone scan done.
Yeah.
Would that complete the workup, or something else would you like to see to find out about the notes?
Yeah, for CT scan abdomen and abdomen,
Exactly.
I want to like to do.
Right. So in that case, is there any other imaging investigation for metastatic workup compared to bone scan and CT?
Yeah. A PMSA scan I would like to go with.
What will be the full form of that?
Prostate specific. I'm not very sure. Prostate specific scan.
Prostate specific what? MCAR? Membrane antigen. Okay, and it is PSMA.
Dr. Rahul, can you please tell me the serial number of this question?
Serial number of the question?
Yes.
Question number 3, sir.
Okay.
Okay, so it is PSMA, not PMSA. Okay, so that is the thing. So out of PSMA PET scan and versus the bone scan and CT. So ideally, if one of your relatives is there, what would you advise?
If patient is affordable and it's available within my region, then I will go with the PSMA scan.
That is what specifically I wanted to ask, and why?
Because it has a higher sensitivity as compared to that of the bone scan, and especially for nodes as compared to that of the CT scan.
Yeah, mainly. Okay, fine. I'll give the summary at the end. What would be your line of management? Okay.
For this patient, we'll give options as the age is 70 years. We'll give the option to patient for the for a radical prostatectomy or the EBRT. Then either depending on
what was the risk stratification of this patient?
High risk patient. We'll go
and
with
what?
followed by adjuvant hormonal therapy, anti-androgen therapy for longer time with the.
So just a minute. So you are saying you are going to counsel the patient either for surgery or for radiation.
EBRT followed by 3 years of ADT.
Okay. And why would you think that you want to do surgery in this patient?
That could be one option which can be given to this patient. But
do you think surgery in itself will suffice as the treatment for this patient?
No, if a post-surgical failure is there, that if PSA failure will look for the early salvage RT also.
And I just told you he's a 70-year-old gentleman. So do you think surgery is going to be an easy option?
No, we'll prefer the option preferred will be the EBRT followed by ADT. That will be my preferred.
Yeah, okay. And again, in this thing also, will it be EBRT followed by ADT, or will there be some kind of another sequencing of ADT and radiation?
Yeah, for this patient, as disease burden is high, so initially I would like to start with the neoadjuvant anti-androgen therapy. After that, I can take patient for the EBRT.
Okay, and how much time after neoadjuvant hormonal therapy would you go for EBRT?
After 6 months, then we can think of EBRT.
Minimum 6 months is okay, but minimum.
Minimum 3 to 6 months. From minimum
3 months is minimum. Yeah, right. Fair enough. So you have to tell me all these answers upfront. Okay.
Yeah.
Right. Okay. Fair enough. Now, what will be your treatment volume? What will be your dose prescription?
Treatment volumes, as it's a high risk patients, I would like to include the prostate along with the seminal vesicles. 2.2 centimeter of the proximal seminal vesicles will be included in my volume. And if I'm planning on CT based planning, then I will give the CTV margin of 3 mm all around. After that, I will give the PTV. And as there is according to Roche formula, there is a high risk more than a risk of a risk of nodal involvement is also high. So for that, I would like to include the pelvic nodes also.
So you would treat the prostate, the seminal vesicle, and the nodes. Am I getting correct? This is what you wanted to say?
Yes.
Prostate, seminal vesicle, and the nodes. Okay.
For pelvic nodes, I'm not sure, but not for the pelvic nodes, only as it's the node negative patients. So I like to go with the only prostate and the seminal vesicle.
Is this your final answer?
Yeah.
Okay. What will be the dose fractionation?
Dose fractionation, either I can go with the conventional or with the 74 grain 37 fraction with 2 gray per fraction, or the 60 grain 20 fraction. I would
okay.
go with the fractionation, that is 60 grain 20 fraction.
Which trial actually postulated this protocol?
This is the trial which has compared 74 grain 37 fraction versus 60 grain 20 fraction and 57 grain 19 fraction.
Fair enough. Okay. So, and in conventional fractionation, you think it's a high risk case, 74 gray will be enough?
Yeah, even in this CHIP trial, they have given 74, including high risk patients also, low risk, intermediate risk, and the high risk.
In CHIP trial, right. But have there been any trials for dose escalation?
I'm not aware about.
Okay, no problem. Fair enough. Sir, Rajesh sir, any questions from your side?
No, please go ahead.
Right. So, Dr. Pallavi, my only thing was you could have been in a little more upfront. Yes, even I had written in bone scan plus CT abdomen pelvis versus a PSMA PET, but then you could have said simply because a PSMA PET, a single investigation, you are getting both bone and visceral mets. So if finances are not an issue, I would like, that would be a straightforward answer. Okay. And the second thing was, please, I mean, we are oncologists and we are radiation oncologists. I know there is a lot of discussion that in high risk, you can do surgery and all that, but at the bottom of the heart, at least this in a radiation oncology forum, in a high risk case, it is always preferred to go ahead with radiation and ADT versus surgery because it will have you will have double treatment for the patient. In a high risk case, there are high chances, maybe sooner or later, the patient may require adjuvant treatment. But yes, ultimately the choice is yours. And the second thing is, yes, you will treat the regional nodes because now there is a paper that says that and you are going in the right direction. So if somebody is poking you, don't change your thing. You are going in the right direction. I'm only confirming with you. That's all. Okay. And maybe in conventional fractionation, you could have talked a little more about dose escalation. 74 is fine, but you are going in conventional, so you can give a range, no? That's what even NCCN says, right?
Yes, sir.
Okay. Thanks a lot.
Thank you, sir. Yeah.
Okay, who is the next one? Please shout
So
your name.
Dr. Afreen.
So now your audio, video, everything is working, Dr. Afreen. Are you here?
Dr. Afreen, please speak.
Hello, yes.
Yes, so I am audible and you are audible as well, right?
Yes, sir.
Okay, fine. So let's shoot. Okay, so you are having a 55-year-old man. He undergoes surgery. So your previous doctor was very much eager for doing surgery. So this one directly went to a urologist, underwent a robotic prostatectomy, which is the fashion of the day. Okay, his presenting PSA was 9 and pathologically his report was saying it was PT3A and 0. Gleason score was 4+3. Apical margin was positive. 3 weeks post-operative PSA is 0.13. Okay. Right?
Okay, sir.
Post-op case, 55-year-old gentleman, PSA 9, PT3A and 0, Gleason 4+3, and 3 weeks post-operative PSA is 0.13. Margin positive.
Yes,
okay, now let's start the questions. How will you decide regarding adjuvant radiation? What is the current guideline? How do you decide regarding adjuvant radiation in post-op cases?
Sir, because this is a high risk case, because the margins are also positive, Gleason score is also 7, I would go for adjuvant RT for this patient.
Is it necessary now to go for it, or there are some other things also that are some evidence that is also emerging that says something else?
Sir, adjuvant RT given just after surgery has a better overall survival because in this scenario, the apical margin is positive in this case. So it's definitely in a high risk case. So
okay, let's say the apical margin was negative. apical margin is negative. Margin is negative, T3A and 0. And then you have this case. Then
So we can keep the patient on observation then.
so like what will you do? I mean, I am the patient. I come to you for opinion. So you say for observation. I'm saying I'll go back to my home in US and probably goodbye, doctor. I'm not going to see you again.
Sir, I would like to do a serial PSA on follow-up. If there is any detectable PSA post-surgery, then I would like to go for adjuvant RT then.
Exactly my point. Now, my question, when will you actually repeat the PSA after surgery? Okay. And what will be your cutoff limit above which you will advise radiation?
Sir, after 3 months, we will do. And if the detectable level is more than 0.4 nanogram, I would like to go for, it can be a biochemical relapse for this case, and we should go for RT in this case then.
What is the minimum period when you can do? You have to do it at 3 months only, or can you do a little sooner also? 3 months is fine, but can you do a little earlier also?
So by a month also we can do.
It's basically 6 weeks. Okay. And are you sure about the cutoff? It's 0.4 only, nothing else?
For more than 0.4, sir.
Okay, fair enough. We'll go to the next question. Now you decide to treat this patient. Okay, you said it was margin positive, and what will be your treatment volume? What will be your dose prescription?
Sir, my treatment volume, I would like to know about the nodal status as well.
N0.
So if it is N0, okay, sir. So I would, and what is the seminal vesicle status, sir?
What did I tell you the stage is?
T3B, okay. So, sir.
T3A, I said. T3A. Read it again. T3A.
T3A. So, sir, I'll be taking whole of the prostate and the seminal vesicle whole. I'll be taking.
Is this a radical case or a post-op case?
Sorry, this is a post-op case. Sir, the post-op bed. I'm sorry, extremely sorry. The post-op bed will be taken in this case, sir.
Okay, and anything else would you like to do?
So whole of the post-op bed will be treated.
Okay, about the nodes?
Sir, if it's N0, we can avoid treating nodes.
Okay, fair enough. Right. What will be the toxicities? Please tell me what will be the acute and long-term toxicities.
So acute will be GI and GU toxicity, urinary toxicity will be there, and sexual toxicity will be there. And in a long-term, patient usually complains of urinary toxicity.
Okay, and we be more specific? What urinary toxicity acute? What is late, long-term? Like how
the patient can complain of stricture, urethral stricture, and dribbling of urine can be there.
Okay,
and,
this is long-term or acute?
Long-term. So long-term, of course. In acute, the patient can complain of burning, micturition, cystitis can be there.
Okay. And okay, just one. Okay, fair enough. And this is all that will be there in acute. So, what other things can the patient present with? Bladder.
Sir, GU toxicity can also, GI toxicity can also be there. Patient may complain of diarrhea or constipation also.
Diarrhea of constipation. Okay. Is it exactly constipation or something else? Fair enough. No problem. Right. So, Rajesh sir, any questions from your side?
Yeah, no, please go ahead. It will be a conflict of interest.
Okay, fine. Right. No problem. So basically, the idea I already discussed that I wanted you to say and talk about this, the evidence that has emerged that you have actually monitored the serum PSA post 6 weeks. And actually it is 0.1 and 0.1 to 2 is considered borderline. Some may say 0.2, but above that you can consider for adjuvant radiation. Okay. And the second thing was, okay, fine. Now this we may agree and disagree whether nodes have to be treated or not. Fair enough. And those, okay. Now what I wanted you to talk about was in toxicity was this patient already will have what post-surgery?
The erectile dysfunction, incontinence.
Incontinence. Most of post-op patients, many of them will be on diapers. So you can say that that can be aggravated. Definitely there will be cystitis, proctitis, but since it's a post-op case, you can also talk about this.
You mentioned doubling of urine, but exactly.
Yes, sir.
Continues.
Right, sir. Okay, fair enough, Dr. Rahul. Okay. Right.
Thank you, sir.
Thank you. Next person? Anyone left?
No, sir. All have done, sir.
All are done.
Yes,
okay.
sir.
If the organizers are okay, we can stop over here, or if you want, we can go for another round because we have 5 more questions.
Dr. Rahul, you conducted it extremely well. Very quick, fast, and very relevant questions.
Okay, sir. Thank you, sir. So we can call it a day then. Rajesh, sir, from your end, it is okay. Any tiebreaker needed?
Then we will be on the right track because 6:30 was the original time to finish it off. So it's already 6:30. So
fair enough.
Let's talk about imaging and simulation. So the first question to Dr. Sushil, what imaging would you do for a patient who's planned for a radical radiation in prostate cancer?
You mean to say the pre-treatment imaging, or ma'am, during the CT simulation as a part of simulation?
Yes, as a part of simulation.
We do CT-based simulation, ma'am.
Okay. Do you also fuse it with any of the other imaging modalities, or you just use a CT scan?
If it is available, we definitely use the MRI because usually we get MRI done before the start of the treatment. If it is not available, then we proceed with the contrast CT.
Okay, so the CT scan is what is usually done, and basically MRI is optional. So not every patient would get an MRI. So Dr. Chandramouli, is that the protocol in your institute as well?
Yes, ma'am. We use contrast enhanced. We use contrast, IV contrast at the time of simulation, and we follow a bladder protocol, and we take a contrast enhanced CT from the umbilicus up to the ambit thigh.
Okay, so
the effectors, and we'll be using MRI, which has been done before, to register and then to visualize the target and OARs accurately, ma'am.
Okay, so what I understand is most institutes do a CT scan and then, if available, MRI. And Dr. Basalat, would you also recommend doing a PET simulation for planning for these patients?
As of now, there is no evidence to use that, but, or concrete recommendations. But PSMA PET scan would show the uptake in the prostate as well as nodes, and also help to look for any oligometastasis or distant metastasis.
Okay, thank you. So, Dr. Sankalp, what is the immobilization protocol and the simulation protocol that you follow?
No, I would like to add on that immobilization protocol. When you're doing a simulation, I would like to do a CT, simulated CT with a contrast CT with specifically 3 mm slices. So that we must not miss any major part. And if we have any MRI T2 contrast, we'll have to fuse it with that. And as Dr. Ravindra has told, PSMA PET, if we have, we can fuse it with that. It will aid in the delineation of our target tissues. And we also must follow bladder protocol. Over here, we follow bladder protocol. We tell the patient to void the urine. I'm talking about simulation. We tell the patient to void the urine, followed by we give 2 glasses, approximately 400 ml of water, and then we take a simulation after 30 to 40 minutes. So this is a protocol which is followed over here. And can I talk about the rectal protocol, which is there on the screen?
Go ahead, yes.
So rectal protocol over here, we follow, we give Dalcolax, that is Bisagodil 20 milligram 3 days prior to simulation. So that, and we also advise the patient before the simulation that take proper hydration and high fiber diet, so that the patient must not, if the patient is having constipation, we must treat that. And on simulation, if the rectal wall is more than 4 centimeters, we don't, we kind of, because of the bowel gas, we kind of reject it and take it the next day. Either we do an enema or we take it the next day.
Okay, Dr. Chandramouli. So what about fiducial placement? So do you recommend fiducial?
For that one, Monica, anybody wants to use oral contrast?
In order to delete bowel bag, sir, actually we can use oral contrast around 1.5 hours before the procedure. That will delineate the small bowel in a better way, especially useful in the case of adjuvant setting when the bowel bag might come in the field.
Yeah, AstroAcrop, sir, can I add? AstroAcrop guidelines also recommend using oral contrast on the day of to delineate the small bowel on the day of simulations.
Okay, excellent. So, Dr. Chandramouli, what about fiducial placement? So, do you routinely recommend placing intraprostatic fiducials?
Not routinely recommended, ma'am, but actually fiducial placement will aid in the delineation of the apex especially, and might be placed in the apex and the base of the prostate where there is difficulty. Apex we are confused with the urogenital diaphragm and the fibromuscular tissue in the urogenital diaphragm, and base we are confused with the bladder. So not routinely indicated, but it's an optional thing, and especially in centers where MRI is available, we can fuse with MRI, and then where we can clearly delineate the apex and bladder. Bladder protocol will also help in delineating the differentiating bladder from the prostate.
Okay, I can see Dr. Basalat has raised his hand.
Yes, ma'am. I would like to add that if we are planning to use ultra hypofractionated therapy, then internal fiducials might be helpful, but they are not compulsory.
I would like
if imaging modalities are used.
I would like to add a few more points.
Yes, please go ahead.
During my MD, we used to place gold markers as a part of routine with the help of TRUS, transrectal ultrasound guided. We used to take the help of urologists. For that, 3 markers we used to place, 2 at the base and 1 at the apex. Mainly, as one of the participants mentioned, it helps in the delineation. More than helping in delineation, it helps in actual matching. Once the CBCT is done, these markers aid in matching, because during the treatment, there is different types of matching we use. One is the soft tissue matching, one is the bone matching, other is the fiducial placement. So I feel fiducial placement is kind of more accurate compared to other kind of soft tissue or bone matching. One more thing is if the patient has natural calcifications in the prostate, we need not place fiducial markers, because those calcification acts as we can match them. So fiducial placement, the intention of fiducial placement is mainly for the matching.
Okay, so just a quick round. What percentage of patients in your respective centers actually get the fiducial placements? How commonly is it done?
In my college where I studied, we used to do it for all the patients, routinely all the patients. But in the SR Institute, we are mainly depending upon the soft tissue and bone matching.
Okay, Dr. Sankar?
Yes, ma'am. Ma'am, in our institute, in my previous institute, we used to do trans-guided fiducial placement, mainly to see the intra-fractionation errors, to mainly match it and while treating it. So in the present institute, around 30 to 40% of the patients who are saying we do it in 30 to 40%. Not all the patients will be, and because we have RGCI and some state-based, we can't do all the things. It is not feasible in our patients.
Okay, there are limitations. Okay, let's go to the next. So Dr. Basalat, for contouring the prostate, how would you do it? Would you do it on the fused images? Would you prefer that, or would you just do it on the CT simulation images?
I would prefer the fused images, ma'am, preferably the T2 MRI of the pelvis. And then also compare it, and then I have to fuse it, register and fuse it with the planning simulation CT scan, and then use both the CT and finally plan and
so
finally
how does an MRI help you over a CT scan?
Yes, MRI, especially the T2 sequence, delineates the prostate capsule as a dark rim to differentiate it from the nearby soft tissue, which would be very difficult, especially the prostate apex and the lateral, posterolateral margins, which will be very difficult to delineate or differentiate on a routine CT scan.
Okay, Dr. Chandramouli, can you just take us through the process for contouring the prostate? How do you begin and what are the areas that you look for?
With respect of contouring, ma'am, in the case of radical intent, initially we contour the organs at risk, namely the bladder, the rectum, and then the bowel bag, and the femur head. So organs at risk, rectum, we start from the rectosigmoid junction.
Let's wait. Let's talk
Target.
about the prostate contouring.
Yeah, regarding the target, actually, we contour the prostate starting from the apex up to the base. The apex is present around 1 centimeter above the penile bulb, and by registration with MRI, we can identify the apex clearly. And so from there, the contouring is started, and superior border would be this bladder, and anteriorly it is separated from the retropubic space and the Santorini venous plexus. Posteriorly would be the mesorectal fascia and the rectum. So with the help of MRI, the prostate capsule is clearly visible, and it can help in delineation of the prostate clearly, ma'am. And laterally would be the levator ani and the obturator muscles. So
Dr. Sankalp raised his hand, and then Dr. Sushil.
Yes, ma'am. I just wanted to add one small point in MR fusion. When you are fusing it with MR, we have to make it a dictum that we have to follow the bladder protocol over there also. 400 ml of prior to MRI, we have to give 400 ml of water institutional protocol, and we'll have to take it because there will not be any discrepancy. Because many a times when we fuse a MR and a CT, it doesn't match much, and the bladder comes in the field of the prostate, and also the rectum also goes back, and we'll be having a bowel gas too. So that is a point which we make sure.
Yeah, that's a good point, Dr. Sushil.
I would like to add in MRI fusion, along with the capsule, actually we can appreciate urogenital diaphragm. That is the actual inferior border of the apex of the prostate. If we are unable to identify that, then we can take alternatively penile bulb. So the advantage with the MRI is mainly to identify the urogenital diaphragm. Also, we can appreciate the vessels, prostatic vessels anteriorly, as well as neurovascular bundles posterolaterally. And it will help in better delineation.
Yeah, that's good. Dr. Basalat, you raised your hand.
Yes, thank you, ma'am. I was saying that I agree with Dr. Sankalp that a routine diagnostic MR of the pelvis will not be helpful. We have to have a coordination and discuss with the. I mean, if we are going to fuse it for the best possible results, we have to have a proper protocol for both the planning simulation as well as the MR.
Yeah, so, and how will you start your contour? Which part of the gland will you start your contour, and then?
Middle of the gland is best for initiating the contour, because it's clearly visible, and then we'll be extending it superiorly and inferiorly. And as we see here,
yeah, so the mid gland is the easiest to see and the easiest to delineate, like you said. And so on this right side image, what is the structure that you see in red? I think somebody had already.
That is the Santorini's.
Those are the vessels.
That is the Santorini's venous plexus.
Yes, so there is a venous plexus which is not well appreciated on CT, but you can see it on the fused images. Okay, that's good. So I think it's Dr. Sankalp's turn. So Dr. Sankalp, can you identify the structures that these arrows are pointing here?
Ma'am, this is the lower arrow which is in the shape of a heart. That is a penile bulb, ma'am. That normally it's the shape of the bladder. It's the shape of a teardrop. So when you go in the superior aspect, you can get the thing. And this is a urogenital diaphragm.
Yes. Anyone else would you add to that? Yeah, Dr. Basant.
That's the urethra.
Okay, actually, this entire this
urogenital.
It is the
diaphragm.
diaphragm.
Yeah,
GUD, yeah. So approximately, what is the separation between the prostate apex and the penile bulb, Dr. Sushil?
Ma'am, it is 7 mm, ma'am.
Okay, anyone else?
It is 1 centimeter above penile bulb, ma'am.
1 centimeter above penile bulb and 1.2 centimeter above the pubic symphysis.
Yes, so it is about 1 to 1.2, 1.3, maximum up to 1.5 centimeters. So that separation is there. And again, we can see in the right side image, basically the difference between appreciating the apex on an MRI and on a CT scan. Okay, so let's move on. Dr. Chandramouli, what is the part of the prostate that you're seeing in this image?
Ma'am, it is the inferior slices of prostate, which is very adjacent to the rectum, and the anteriorly we have left a concavity to account for the urethra. Urethra is not included.
Okay, so you're saying inferior. Can you want to revise that? What structure can you see, or anyone else wants to take that?
The levator is in surrounding. Posteriorly, the rectum is abutting, and
this is the base of the.
Actually, ma'am, as we can see that the base of the base of the prostate rests on the trigone of the blood.
Yeah, so Dr. Pasalat and Dr. Sankalp, yes, you are right. This is the base of the prostate, and the urethra is
trigone of the bladder, and we can clearly delineate it by taking a IV contrast. That helps us in delineating the bladder wall and the prostate, which is not probably seen properly in a CT scan. So IV contrast is very important in such case.
Yes, and Dr. Chandramouli, raise your hand, and then Dr. Pasalat. Dr. Chandramouli.
Yes, ma'am. I said it is the base of the blood prostate at the level of the which is superior to the bladder, ma'am. Yes, ma'am.
Yeah, Dr. Pasalat.
Yeah, I was saying that this is the so-called butterfly shape that should come at the base of the bladder when we exclude the urethra.
Yes, you're right. So as per EORTC guidelines, they recommend contouring it in this butterfly shape and keeping the urethra out of the contour. So, unless there is evidence of urethral invasion.
Yes.
Dr. Sushil, what about seminal vesicles? When do you include seminal vesicles? What are the indications? And then we'll move on to discussing how do you contour them.
Usually, seminal vesicles contouring is indicated in intermediate and high-risk prostate cancer. In intermediate risk prostate cancer, 1 centimeter is suggested as per the guidelines, whereas in high risk, we need to include 2 centimeters or entire seminal vesicles.
Okay, and Dr. Chandramouli, how do you contour the seminal vesicles?
Yes, so seminal vesicles actually in the case of low risk, intermediate and high risk. Intermediate, we include the proximal 1.4 this millimeter of the seminal vesicle, and in the case of 1.5 centimeters of the seminal vesicle, and in the case of high risk, it will be the proximal 2.2 centimeters of the seminal vesicle, and this is according to one Key et al. Recommendation, ma'am. And in low risk, the inclusion of seminal vesicle is optional. It can be avoided, or it can be proximal 1.4 centimeters can be included. It is according to the Eastro-Akarop guidelines of contouring.
Okay, so Dr. Pasalat and then Dr. Sankalp, you have both raised your hands.
Yes, ma'am. Everything has been told by the previous people. According to ASTRO guidelines, I just like to add that ASTRO guidelines does not recommend inclusion of seminal vesicles in low risk. And if there is invasion, we'll have to include that in the CTB and also into the intermediate risk and the high risk. As I told, proximal 1.4 centimeter in intermediate risk, and in high risk, proximal 2.2 centimeter, according to ASTRO guidelines.
Okay, Dr. Pasalat, you wanted to add anything?
Yeah, I was going to say the same thing to add to Dr. Sushil Kumar. nowadays they are usually recommending to keep it 1.4 centimeters for the intermediate risk and up to 2.4 centimeters. Just
I would like
what
to
Dr.
add.
Sankar.
I would like to add one point. The measurements which you are saying 1.4 and 2.2, they are according to the RTOJ guidelines. There is also ESTRO-ACOP guidelines where still it's a recent publication. Still they are recommending proximal 1 centimeter and proximal 2 centimeters. So it all depends upon which guidelines we are following.
Yeah, that's true. But I was referring to the ESTRO-ACOP 2008.
2018, Salambeer et al.
Yeah.
Okay, so yeah, that is actually
And-
from the paper by Key et al., as you mentioned, in which basically this is how they've described the contouring of the seminal vesicles. So Dr. Chandramouli, can you tell us what is this structure which is medial and superior to the seminal vesicles?
Ma'am, it's the ductus deferens, ma'am.
Yes.
And it should be excluded while contouring because it need not be radiated, and it's more clearly visible in MRI also. And yeah.
Yeah,
So,
okay, that's
and
right. It's the ductus deferens, and it can be usually when you contour on a CT scan, it is included. It's not really excluded or separated as a structure, but the recommendation is that it doesn't need to be irradiated. Okay, you're right. So, okay, then Dr. Sankalp, I think we've already discussed about this structure
Yes, ma'am.
that's been marked
Yes, ma'am.
star. So, can you identify that?
Okay, ma'am. We can see the crura, and between that there's a typical teardrop shaped structure that is a penile bulb. So while drawing the penile bulb, this serves as as a basis for identifying the apex of the bladder. So a penile bulb is very important, and penile bulb actually gives us an idea of all the vessels and the neurovascular bundles over there. So limiting the dose to the penile bulb can actually help to prevent long-term complications such as rectal dysfunction or something like that.
And Dr. Sushil, you raised your hand.
That was for the previous question, ma'am. But however, I would like to add one more point. Yeah, like Dr. Sankalp told, it is mainly to reduce the incidence of erectile dysfunction. But erectile dysfunction is also related to the injury to the neurovascular bundles, which are near to the, penile bulb.
Yes, that's right. So therefore, it's important to identify and delineate and spare the structure when you're doing the radiation. So Dr. Chandramouli, what about PTV margins? How do you decide your PTV margins?
PTV margins, ma'am, as usual, it is institutional based. In our institution, we follow around 1 centimeter in all the directions, except for 5 to 10 millimeters, 5 millimeters in the anteroposterior direction for the prostate and seminal vesicle. And for the lymph nodes, we follow 1 centimeter symmetrically in all the directions.
Okay, Dr. Basalat, you raised your hand.
Thank you, ma'am. For the seminal vesicles, I would just like to add that we should be careful when following the guidelines to include the actual proximal 1.4 or 1 centimeter of the seminal vesicles, and not, so we should look at all we should go in the plane of the seminal vesicles.
Yes, that's right. That is what the paper actually emphasized, that rather than just going in the XYZ direction, you have to go in the plane of the seminal vesicles and measure it in the plane. That's right. Dr. Sankalp, you also raised your hand.
I just like to add on the PTV margins. Several institutes have different protocols. In our institute, we follow 1 centimeter uniform margin, and posteriorly we give a 7 mm margin. That's the thing which we follow over here, so that dose to the rectum can be decreased.
Okay, Dr. Sushil?
Ma'am, like everybody are saying, that's right. The PTV margins are totally institutional based. But if we are planning to do CBCT, and if we have a proper matching system, then 5 centimeters around and 3 mm posteriorly will be sufficient.
Yeah, 5 mm. Yeah, it depends on your imaging protocol. Basically, the frequency of your imaging protocol also.
Ma'am, the ACROP guidelines also states that we must not go below 5 mm the PTV margin. We must not go below 5 mm margin because of the chance of misses and because of interfractionation motion. They have recommended that not less than or equal to 5 mm.
Yes,
as a part of a
there
PTV.
are always uncertainties. You're right.
Yeah.
Dr. Chandramouli?
Yes, ma'am. I'd like to add that the prostate motion itself is around 2 mm due to the rectal and bladder filling. And the most important thing, as pointed out by others, is this image-guided protocol, and bladder and rectal filling has to be strictly followed every day by the patients, and it is to be ensured by the treating physician, so that this PTV margin is catering to the treatment accurately.
Yes, and also would it differ your PTV margins between if you are giving conventional fractionation versus an SBRT or a hypofractionation? Dr. Chandramouli? You raised your hand.
Yes, ma'am.
Dr. Basalat?
Ma'am, can I add, ma'am? Can I add?
Yes,
ma'am, it doesn't depend on whether you're doing a SBRT or a conventional. PTV margin based on the errors, the errors which are there is because of the institutional protocol. For a SBRT, we won't, even though we take tight margins in seeing that there's no margin of error, but both are the same in either conventional or in a higher mode of radiotherapy. We follow the same PTV margins.
Okay, so basically, I think the agreement is that it depends on your imaging protocol and your degree of immobilization. Okay, let's.
I have one question. Hello, Monica?
Yes, yes.
Yeah, anybody wants to touch upon extracapsular extension? Or to incorporate in your contouring?
Yes.
In high risk cases.
Dr. Basalat, I think.
Yes, sir. Extracapsular extension is actually best seen on the T2 MR sequence again as a high signal intensity, and the guidelines recommend that it should be
high risk
included.
case is there. If you don't have MRI also, how to incorporate that? If you have MRI, then it's good. So
yes, sir. Sir, I think the CTV, the margin should be sufficient enough to cover that. Routinely, we do not use the Roche formula or any other thing to predict that. But if there is there's still going to be there could be a microscopic extracapsular extension which will not be revealed on even MR imaging, sir.
Can I add?
I would like to add.
Yes, Dr. Sankalp and Dr. Chandramouli, they raised their hands.
Ma'am, if there's extracapsular extension, we'll have to give a margin to it. So we give a margin of around 5 mm margin, and we exclude the rectal wall. So it doesn't, posteriorly it doesn't go beyond the rectal wall, but we give a margin if it is EC is positive. And if EC is extracapsular extension is not present, we don't give any margin.
But it's quoting ACROP guidelines 2018. It is not 5 mm, no? It is just 3 mm.
3 mm margin, and according to ACROP guidelines,
yes, sir, they
give
have
a specific thing
3
that 3 mm margin must be given, and to point here, their mention is that exclude the rectal wall. This was a thing which was given in the ACROP guideline, but in our places, in our institution, we follow, if this EC positive, we give a 5 mm margin to the process to be included in the CTV primary.
Okay, Dr. Chandramouli, you raised your hand.
I would like to add that in the case of extracapsular extension, the margin that we give 3 mm, it is not given posteriorly and superiorly also. Posteriorly, we want to cut it off the rectum. When there is no rectal infiltration, there is no use in giving that margin. And superiorly also, we are not giving. So, and another thing is this margin to account for extracapsular extension in CT is just a safety, so that if we are having a MRI, we can clearly delineate extracapsular extension, and there is no need for that margin. In the CT scan, we are not able to clearly see the extracapsular extension, so we are giving that 3 mm margin. And another thing is in the case of low risk diseases, this extra extension to cover the extracapsular extension is not needed. This margin that we give 3 mm is needed only for intermediate risk and high risk prostate cancer, according to D'Amico risk stratification, according to Easter Akram.
Thank you. That was a good point that was raised. Coming to post-operative radiation now, Dr. Sushil, what are the indications when you would consider post-operative RT for prostate cancer?
If there is extracapsular extension, or if there is margin positive, these are the two indications where we consider post-operative radiotherapy in prostate cancer.
Okay, Dr. Sankalp raised his hand.
Ma'am, according to ASTRO guidelines, they have given specific 3 points in giving an adjuvant radiation. The one is PT3A, positive margins, and seminal vesicle involvement. So these 3 things, if they are present in the histology, we have to go for adjuvant post-operative radiation. Within 1 year.
T3 is nothing but it's extracapsular extension.
Yeah, that's what. Specifically 3 were given in that ASTRO guidelines.
Yeah.
That's good. Dr. Chandramouli?
Yes, ma'am. The same thing, that margins positive and extracapsular extension and seminal vesicle invasion are the 3 major indications.
Okay. So what would be the CTV? If it's a post-operative RT, how do you decide your CTV? Dr. Sushil Kumar raised his hand.
Since there is no prostate per se in the post-operative field, we need to take a few bony and soft tissue landmarks in order to delineate. So as per the guidelines, they have given with 2 areas, that is the lower part of the prostatic bed and upper part of the prostatic bed. In the lower part of the prostatic bed, the inferior margin starts above the vesico-urethral anastomosis. And in CT scan, it's very difficult to find. And if you are unable to find that, then we can very well start 1 section above the penile bulb or 7 mm above the penile bulb. And anteriorly, it is the posterior border of the pubic symphysis, posteriorly it is the rectum, and laterally the levator ani. As we go superiorly in the upper region, the posterior border is the, now it is the post-op bed. So in the place of prostate, the bladder will take over. So we need to include in the upper part 1 to 2 centimeters of the bladder. And laterally, it is the same levator ani muscle, and posteriorly, it is the rectum. And superiorly, if there is seminal vesicle invasion, so that's what one of the indication. We need to include the remaining part of the seminal vesicles, if not resected.
Okay, thank you. So, Dr. Chandramouli, you wanted to add something?
Yes, ma'am. Actually, it is broadly classified as with the superior border of the pubic symphysis. So above the superior border of pubic symphysis, the border should be anteriorly the posterior 1 to 2 centimeter strip of the bladder, posteriorly the mesorectal fascia, laterally the sacrogenito-pubic fascia, and superiorly it will go up to the cut end of the vas difference, ma'am. And roughly, sometimes what happens, the vas difference gets retracted post-op. So it is better to take 3 to 4 centimeter above the this head of the acetabulum. So this inferiorly, the part below the superior border of pubic symphysis, the anterior border would be the symphysis pubis. Posteriorly, it will be the rectal wall. Laterally, it will be the levator ani and the obturator muscles. And inferiorly, it will go
yes.
8 to.
So the same thing that was already told by Dr. Sushil.
Yeah.
Dr.
One
Basala?
thing I would like to change is it is 8 to 12 millimeter below the vesico-urethral anastomosis, ma'am.
Yes. Dr. Basalat, you raised your hand, and then Dr. Sankalp after you.
Thank you, ma'am. I agree with the previous speakers about the margins, but for the indications, I would just like to add that for now, even early salvage is recommended, not just.
Yes.
So in the artistic meta-analysis, they have found they are suggesting that early salvage RT will be better compared to
Yes,
late
so
adjuvant.
as per the trial, and there was no difference in overall outcomes. Okay, So, Dr.
I
Sankar
would like,
wanted to
I would
add.
like to have one or two things, ma'am. Everything has been told by the previous speakers. So in our institute, we take around 1 to 1.5 centimeter into the bladder apex. As previously told by Dr. Sushil, 1 to 2 centimeter. Here we take 1 to 1.5 centimeter, and we have in a CT scan post-op, we won't be able to see much of the things because of the signal intensities and everything. So we make it a basis that we identify the penile bulb. We go, we basically identify the area of the apex, it might be. So 1 centimeter above the penile bulb, 1.2 centimeter above the caudal edge of the pubic symphysis, 1 to 1.5 centimeter above the obturator foramen, or approximately 3 centimeter above the ischial tuberosity. So this is the basis which we find out. So it's kind of tough to identify the reason. And rest all the speakers have told.
Yeah, so basically, and post-operative surgical clips will be very helpful, I think, in delineation. And whether you're talking about early salvage or immediate post-operative RT, in case there is no demonstrable recurrence, the CTV remains the same. So we can just see in these images, this is one of the suggested CTV delineations for post-operative, where they have, this is the lower border where they've taken this as the anastomosis near the vesicle, the urethral anastomosis basically. And then as you go up, you can see that you have to go more laterally to include the tissues behind the bladder, and also it's almost going up to the obturator internus muscles. And then in the area of the seminal vesicles, if that has to be included also, the contour extends more laterally. So the contours are definitely much more larger than the contours for an intact prostate. Okay, so anyone wants to add anything else before we close the session? You can raise your hands and...
Monica. Right?
Yes, sir, Dr. Srinivasan.
Yeah, just, okay. So you'll be talking about external RT. I just want to know, like, how many of you guys will be interested in prostate brachytherapy, and what do you think is the ideal patient for prostate brachytherapy?
Sir, the ideal patient for the prostate brachytherapy will be the low risk category or selected intermediate risk category.
Okay. What about others? Yeah. Do you have any exposure to brachytherapy?
Certainly patients who have not undergone a TURP.
Ah, okay. Dr. Giri said something.
Yes. That's
okay, right. Over to you, Monica.
Yes. Okay, so I think we've almost reached the end of the time for our session. So any last comments? I think I would just ask the participants one by one. Dr. Sushil?
Any more points to add, ma'am?
Yeah, anything else that you want to add?
Yes, ma'am. Regarding the prostate brachytherapy, I would like to mention a few things because I have seen the prostate brachytherapy procedures.
Go ahead, go ahead.
Yeah, just very pertinent points because we don't have time.
Yes, ma'am. First point comes is in US, they practice what is called as spacer that separates the prostatic tissue from the rectum, thereby decreasing the rectal doses. And rest of the procedure is same, like they place a template and then they put the interstitial needles and they plan. But one thing I want to mention is the regarding the spacer, which here in India, I'm not sure whether we are using or not.
This is preferred for iodine implants, permanent implants, not for HDRs. HDR you can optimize, no, it's not a major problem.
Yes, sir, but
at Tata Memorial, they are using that, I think, for SBRT cases.
As a part of routine, they are using in few centers in USA, sir.
Yeah.
Even for the HDR brachytherapy.
Yeah, but also for external beam also it has been used and it has been found useful. Dr. Chandramouli, anything else to add?
Another thing is there is one issue in the post-op setting. CT artifacts could be created by the fiducials. Another thing is hemostatic clips might be placed by the surgeon, and that should not be confused with the post-op bed clips. Hence, pre-op imaging can be fused. Pre-op CT imaging can be fused in the post-op simulation CT, and that would aid in the delineation of the tumor, prostate
That's
tumor
a
bed.
good point. So you need to review the pre-op imaging and also discuss with the surgeon. Dr. Basalat?
Yes, thank you, ma'am. I would just like to say that beyond all the guidelines, it is very important to have a proper bladder and bowel protocol, which is tailored for the patient, for every patient, differently for every patient, depending on his or her requirements and needs.
Thank you, Dr. Sankar.
Ma'am, I would like to add one more important thing. No one has spoken about hypofractionation. Hypofractionation carcinoma of prostate chip trials, so many trials have come out, and so it is the like treatment of choice. For example, either we can go in 70 grain, 28 fraction at 2.5 gray per fraction, along with 60 grain, 30 fraction at 3 gray per fraction. And also, I would like to add upon, if we have a positive note, we can actually give a SIB in these cases. Along with the normal nodal RT, when we are giving the dose, we can give a simultaneous SIB in such cases. For example, we can go
Yeah, okay, Dr. Sankar, basically your point is valid, but because the discussion was focused for this on tumor delineation or the target delineation,
I would like to add up.
we did not discuss those points. Otherwise, there's a lot to discuss about both tracking, imaging, and dose prescriptions. And so, in the end, Dr. Srinivasan, closing comments from you, sir. So you raised your hand. Okay, so I think we can conclude our session. And thank you to all the participants for a very interactive and very fruitful session. And I thank the judges, Dr. Srinivasan and Dr. Siddhana, also for actively participating and giving their sharing their perspectives and comments.
Thank you, Dr. Monica, and thank you to
yeah, hi, good evening, everybody. So,
good evening, sir.
Yeah, so I think you all are doing prostate contourings regularly in your respective hospitals. So, just we will brief on what are the important points and how target delineation has to be done in pre-op setting, post-op setting, and nodal, whether it is important or not, and when exactly, seminal vesicles, when to contour, when not to contour, and how to contour. So, first is immobilization, how we're doing immobilization, and then bladder protocol, what all you are following, rectal protocol, and fiducial placement. Surgeons after surgery also sometimes they put markers for our post-op setting to when there like advanced disease is there. We need to include that marker when you are contouring for post-op RT. And now coming to MRI, how useful it is and how it gives extra advantage over CT or not. And then fusing PSMA with PET, whether it is beneficial or not. So the most vital but the neglected part is the patient setup. So anyone can. So first of all, I'll ask, Laurie is there?
So yes, I'm there.
Yeah, so let me know what is your bladder protocol you are following?
So in our institute, we as of do not follow any bladder protocol. We include the patient in empty bladder, sir.
Okay.
Because the immobilization using any bladder protocol have do not show any such rectal position variation, and in other studies also it has been shown that using any bladder protocol does not improve the prostate immobilization, although the high doses to the bowel can be prevented if we use any bladder protocol.
So what about rectal protocol?
So we use laxatives 5 nights, 1 week, 5 nights before a simulation, because most of the patient do not have a good bladder emptying, rectal emptying as of. So we give laxatives 5 nights before, and then on the day of simulation, if the rectum is not distended, then we simulate, and depending on the situation as of.
So what benefit you will get in an empty rectum, and like if you don't follow rectal protocol and if you follow rectal protocol, what will be the difference?
So can you please repeat, sir?
What will be the difference in terms of contouring and toxicity if you are following rectal protocol and if you are not following rectal?
So if we do not follow a rectal protocol, the most problematic thing is that during the radiation, as the radiation continues, the rectum starts to, if we do it in a full rectum or we not follow any rectal protocol, as the patient proceeds with the treatment along with radiation, the volume of the rectum starts decreasing, or there will be an irregularity with the rectal fill-up. So as a result, we may miss our target volume. The prostate may go much anteriorly or posteriorly. As a result, we may miss the vital target volume, which is prostate. And also, it has been proven if we do not follow a specific rectal protocol, if most of the rectum, if it comes in the radiation field, that is, if most of the rectum, that is around 70%, receiving more than 25 gray, it will lead up in late toxicities like proctitis and all those things.
So this is a full rectum, and this the difference is when you are doing comparison, this is a empty rectum. So the difference is in the range of 1 centimeter. When the rectum is full, it will push it 1 centimeter anteriorly. So that's why rectal protocol is so important. Okay. So let's come to CT-MR fusion. Whether CT simulation is enough or there is any advantage of adding MRI fusing with CT. So what benefit and if it is required or not? I will ask, I think, Janvi, Dr. Janvi Das. Janvi, you are there?
Yes, sir, I am there. Sir.
Yeah.
Sir, CT and MRI fusion is required, sir. It is important. So in CT, the genitourinary diaphragm is not visible. It is not prominent in the CT, which is we can delineate the genitourinary diaphragm better in the MRI. So while delineating the seminal vesicles also, MRI is required. So that's why CT and MRI fusion is mandatory.
Is that the only benefit?
Sir?
Is that the only thing we can see? GDU, genitourinary diaphragm, GUD, or anything else is any other benefit?
Seminal vesicles and,
okay.
And the penile bulb also.
Exactly, penile bulb, ureter, and muscles all are clear. So I'll just tell you the benefits of adding MRI. MRI is superior to CT in defining the zonal anatomy and the periprostatic infiltration also. And there has been significant improvement in MR techniques as well right now. So performance of imaging prostate has increased. And adding MR spectroscopy, so prostate cancer can be identified by difference in the level of citrate and choline. So a significant reduction in prostate citrate and significant increase in choline related to the normal the prostatic zone has been observed. So combining MRI and MRSI, the specificity has increased in the range of 91% and sensitivity to 95%. So MRSI sometimes can be very useful to accurately localize the prostate cancer and distinguish between the tumor and post-biopsy hemorrhage. Follow-up, even after treatment for follow-up, it will be helpful, and development of more focused therapy may also be productive for tumor to know the tumor aggressiveness based on the choline uptake of choline. So coming to how to contour. So the discussion, we have to exactly contour the prostate, the prostatic apex, which is a little bit hazy in the tissues, local tissue there. So you have to be very specific about finding the prostatic apex. penile bulb, which is very important. So I'll tell why it is important, because surgeons versus radiation oncology, the main concern is about the erectile dysfunction, so which we have to spare penile bulb out of the treatment volume. So that's why identifying penile bulb is very important. Seminal vesicle. So seminal vesicle, where there is a lot of controversy whether to irradiate or not.
केमिस्ट्री का मम्मी को सुना के ना क्लास में.
So seminal vesicle, there is a lot of controversy whether to irradiate or not. If you are irradiating in some cases, whether full volume has to be irradiated or part of seminal vesicle has to be included. And then CTV margins, then elective nodal radiotherapy, whether it is required, if required, in what cases it is required, and to what dose we need to give it. And then about the margins, PTV margins, and then the rectal dose is very important. So the anatomy, I will go a little bit into the anatomy, like this transitional zone, the anterior region of the fibromuscular stroma, which we have to exclude from the treatment volume, transitional zone and the peripheral zone. So anyone, my question to Avik?
Yes.
Yeah, Avik, can you elaborate the margins, anterior, lateral, and posterior, while doing the contouring of intact prostate?
Yes, sir. For contouring the intact prostate, I would like to start contouring from the apex. Apex is around 1 centimeter above the penile bulb, and I will exclude the genitourinary diaphragm and will start the contouring of apex from around 1 centimeter above the apex. And defining apex, for the defining apex, the registration of MR-T2 MR with CT is very much helpful. And after identifying the apex region, I will go above along the prostate gland, so more cranially. I will exclude levator ani muscles, and for the intact prostate, the anterior border of the intact prostate.
Anterior, posterior, lateral, yeah.
Yeah. So for the anterior border, the base of the prostate is sometimes lies in continuity of the base of the bladder. So for that part, we must be very much careful. And for the lateral part of the prostate, excluding the levator ani, and for the seminal vesicle part, I would like to include the proximal 1.2 centimeter of the seminal vesicle if the disease is favorable intermediate group. And I will like to extend up to 1.4 centimeter of the proximal seminal vesicle if it is unfavorable intermediate or high risk category.
Yeah. So like you said, anterior, include the anterior fossa and exclude the fat area in the front of the anterior fossa unless protrusion of the prostate is visible in the CT scan or MRI. And MRI, so retropubic space has to be like excluded unless it is infiltrating them. Lateral, as you said, levator ani muscle, and posterior anterior wall of rectum.
Yeah, yes, sir. And if there is any evidence of extraprostatic extension, I would like to include. I would like to give around 3 millimeter of margin in and around.
So, and regarding the apex, prostatic apex, as you said, it is at least 1 centimeter above the upper limit of the penile bulb. So so there lies a clear diaphragm in between the so this urogenital diaphragm in between the prostatic gland and the urethral bulb, and you need to spare the urethral bulb from the radiation body. So this is one of the diagrams showing penile bulb in MRI, how clearly it is visible, which is very hazy if you see in CT. So this is the CT comparison with MRI. Urethral penile bulb is so clearly visible here, which is not clear in CT scans.
Yes, sir. And if it is better if the urogram is available, but very few centers provide this urogram.
So now coming to structure deletion in prostatic radiotherapy, the trick is identifying the prostate apex and its relievers, anterior fibromuscular stroma at the mid prostate level, which has to be excluded, and the contouring errors has to be at the prostate base has to be carefully done, and seminal vesicle as a target, when and how much to be taken. As you said already, the proximal part has to be included in wherever indication. So recommended is, we recommend excluding seminal vesicle from CTV in patient with prostate cancer treated with definitive radiotherapy who have a pre-treatment PSA less than 10, as you said, low risk group, which is PSA less than 10, Gleason score less than or equal to 6, or stays less than T2A. So the funda is less than, so 50, less than 15% chance of involvement should be there, roughly. So there it is not required. When the chance of involvement is around more than 15 or more than 15, that time we have to include it. So T3 disease, it is recommended. And coming to OARs, so who is left? Avinash. Yeah, Avinash, you are there? Hello. Hello.
Yes, sir.
Avinash, you are not audible.
Yes, sir.
Okay, Avinash, tell me about the OARs and their dose constraints. Avinash, we cannot hear you. Any others can hear him? I am not able to hear him clearly.
Dr. Avinash, can you please stop your video? That will be improve your internet quality.
Hello.
Yeah, hi. You can tell. Hi, Avinash. Hello. Okay, leave it. I think I will ask somebody else.
Am I audible, sir?
No, you are not clearly audible. Anyway, so Dr. Luri, can you tell about the organ at risks and the dose constraint about the organ at risk? I will come to you later, Avinash.
Sir, am I audible?
Yeah, you are audible. Please go ahead.
So my organ of OARs for prostate contourings will be rectum, bladder, seminal vesicle, rectum, bladder, penile bulb, and the bowel bag.
So what are the dose constraints?
So, so for the rectum, we will try to.
So,
hello.
Yeah.
Yeah. So for the rectum, we will try to achieve a dose constraint so that less than 25% of the rectum receives 70% of the dose, and also for the bladder. So
I think there is some network issue. Sorry, we are not able to hear it clearly.
Hello, sir.
Yeah. Tell me, what is the dose you are following right now? Is it the hypofractionated regimen, or you are still following the long course? Yeah, we can hear you. I can hear you. Tell me which protocol you are following now.
Yeah,
is
so
it the,
because there is some network issue out here, the voice is getting.
Yeah, correct. We are not able to hear you properly. Right now, we can hear you. Tell me.
So, currently, so we are practicing conventional dose fractionation, which is a 1.8 gray and 1.8 to 2 gray, and we if we consider irradiating the whole pelvis, we irradiate up to 45 gray in 25 fractions for the whole pelvis, followed by a boost to the prostate, or if the seminal vesicles are included, then up to another 19 fractions at a rate of 1.8 gray, which totals up to 79.2 gray as a whole.
Okay. So anyone following the short course hypofractionated regimen 60-20?
No, sir. We do not have practiced a hypofractionated regimen in our institute. So this is the conventional one only we are practicing out here.
Okay. Anybody else like Avinash, Avi, anybody?
At our institute, we do follow hypofractionation for selected patients, especially for the intact prostates.
Exactly. Right now, I'm talking about intact prostate only.
Okay. Sir, we usually follow 2.5 gray per fractionation for 28 fractions, or like 2.7 gray 26 fractions, the moderate fractionation schedule.
Dr. Sanjay, sorry interrupting you. Dr. Parida has been joined.
Yeah, I saw him.
So,
Namaste.
Sir, welcome, sir. Sir, please unmute yourself, sir. Please unmute yourself, sir.
Dilip, sir.
Sir, we have started the competition. Welcome, sir.
Right. Sorry for the delay and the problem. There are some network issues.
Not at all, sir. We have started the program. So I request all four participants to introduce to Dr. Parida. So it will be helpful for him for giving you marks. And sir, Dr. Sanjay has taken the moderator as well as judge. So he will consult you at the end of the session to who will be the winners.
Yes.
Okay, sir. Should we go ahead, sir?
Right.
Okay, sir. Please go ahead.
Let them introduce also to each part. All the junior doctors, introduce yourself to Dr. Parida.
Good afternoon, sir. I'm Dr. Abhishek Mandal. Presently, I'm working as a senior resident at AIIMS Patna, All India Institute of Medical Science.
Right.
Next one.
Good afternoon, sir.
Hi, good afternoon.
Sir, I am Dr. Louis Bora. I am currently working as a senior resident in Dr. Cancer.
Very good.
Third one.
Good evening, sir. I'm Dr. Janvi Das. I did my MD from JIPMER and I'm presently working as a senior resident from State Cancer Institute, Guwahati.
Good.
Thank you. Yeah.
Yes, Dr. Avinash.
Well, hello, sir. Good afternoon, sir. Avinash Bharjana. I'm currently working as senior resident Department of Radiotherapy, AIIMS Bhubaneswar, and under the guidance of our HOD, Dr. Dilip, Professor Dr. Dilip.
Okay.
Don't disclose it.
Welcome all, and Dr. Sanjay, please continue. Yes. And at the end, please help me.
Yes, you're right. Yes. Thank you. So, yeah.
I'm sorry, sir. I got in between. Shall I continue?
Yeah, no, I'll ask you.
Okay.
Yeah. So now coming to post-operative radiotherapy. So Avinash, tell me what are the are you following post-op radiotherapy for some category of patient, or you are waiting till the PSA level raises? What is your protocol? How you are doing?
Yes, sir. In patient post radical prostatectomy, if there is indication of post-op radiotherapy, adjuvant radiotherapy, we do give adjuvant radiotherapy.
What are the indications?
Indications include T3. Indications include T3 stage, if any node positive, if there is any involvement of seminal vesicles. We do give in these scenarios adjuvant radiotherapy. Also, there is an indication for salvage radiotherapy. For serial monitoring of PSA, there is a rise of PSA level to 0.2 nanogram per ml. In that scenario, also we consider giving a salvage radiotherapy.
So, just I'll elaborate and then ask. So, indication in CTV, indication earlier standard was early adjuvant RT for all T3A and 3B and margin positive cases, and of course nodal positive cases. But current standard, most of still people are practicing post-op adjuvant RT in all these cases also. But many centers, they are waiting for early salvage RT and PSA unless the PSA level is detectable in the range of 0.2, as you already said. So there are many artistic meta-analysis, radicals of RT, rares and GTOC AFU17. Based on that, the practice is changing. And now, Avinash, you tell me the post-op guidelines, like how you contour above symphysis pubis and below symphysis pubis. What are the margins, anterior, posterior?
Yes, sir. We do follow this RTOG guidelines to control post-op prosthetic bed. In there is two scenarios where we contour the superior edge of pubic symphysis and above the superior edge of pubic symphysis.
Yeah.
In case of below the superior edge of pubic symphysis, anterior margin includes posterior edge of the pubic bone, and the posterior margin is our anterior wall of anterior rectal wall, and the inferior margin is around 1 centimeter above the vesico-urethral anastomosis, and our lateral includes the levator ani muscles or obturator international muscles, which is attached to the lateral.
Yeah.
And in case of above the superior edge of pubic symphysis, the anterior includes at least 1 centimeter of the bladder wall is included anteriorly. Posteriorly, we include the mesorectal fascia, and superiorly, it is either at the cut of vas difference, or we take around if we have a 2.5 slice, like we take about 16 slice, like 4 centimeter above the pubic superior symphysis, we take around that. But we try to distinguish the cut end of vas difference. At that level is our superior end, and laterally we same as levator ani muscles, so includes our levator ani muscles.
While doing the contouring, do you take see both the coronal and sagittal things? Is it required?
Yes, sir. We need to actually incorporate. We do contour in the axial section, but we need the help of coronal and sagittal sections to rule out any extra bulge or extra part of some normal structure is involved, to carve out all those things.
As you said, it is the anterior margin below the superior edge of symphysis pubis. The anterior margin is posterior edge of pubic bone. Posterior is the anterior rectal wall, and inferior 8 to 12 millimeter below the vesico-ureteric anastomosis that we have to find out comparing the MRI. And laterally, it is levator ani and obturator intermuscular. So may need to concave around the lateral aspect little bit while doing the posterior margin, and may include more if concerns for apical margin is there, then include little more also. So based case to case, the scenario may change. And above the superior edge of symphysis pubis, the anterior margin is posterior 1 to 2 centimeter of the bladder wall, and posteriorly it is mesorectal fascia. Superior it is, as you said, it is a level of cut end of vas difference, or that is roughly 3 to 4 centimeter above the top of the pubic symphysis. Vas may retract posteriorly little bit, so include seminal vesicle remnants if pathologically it is involved. So these are the, if somewhere if it is surgical clips are there, we have to include that. So these are the diagrams I'll be post of guidelines, and a little bit like some other guidelines, adding the Australia and New Zealand guidelines. 5 to 6 millimeter below the UV anastomosis, they consider that as the inferior margin. Superior, they cover seminal vesicle and vas difference. So that's fine. So as the guidelines, we have to consider what is correct for each patient. So individualized therapy, sometimes the clinician discretion is very important. So what was the initial disease before surgery, and where if there is an extra prostatic extension, exactly where was that? So according to that, the contour may vary a little bit. So were the seminal vesicles involved or not, and was there a positive margin? If so, exactly where? So these things are important. So coming to the CTV volumes, when the nodal things are considering Acha. So I'll ask. Should I ask? Give me a minute. Yeah, Avik, did I ask you?
Yes, sir.
Yeah,
Sure.
I asked you, you explained me. Janvi. Dr. Janvi?
Yes, sir.
Yeah. So tell me what is the indication of nodal irradiation, and are you doing, and what, and exactly in what scenario you are including nodes, and how much dose you are irradiating?
Sir, we are including the nodes. Prophylactically, we are including the nodes. In prophylactic, if the node in node negative, if the in cases of high risk, favorable intermediate and unfavorable intermediate, as well as the high and very high risk, we are including the nodes, even if it is N0 prophylactically. So prophylactically, we will give 55 gray, and if node positive, then we have to give the full dose. We are practicing the conventional, so we will give around 80 gray. Full dose to the, if node positive it is there.
So, like, is there any benefit adding nodal radiotherapy?
Yeah. Yes, sir. Actually, yes, sir. There is a benefit, sir.
Tell me. Significant studies.
Sir, one study still presently it is going on, that is RTOG 0424, 0924 about nodal irradiation. It is still ongoing, sir. So they have, so this topic is a little bit of controversial. So
does adding nodal radiotherapy increases the toxicity?
Yes, sir. Nodal irradiation increases the toxicity. It increases the bowel toxicity.
Okay, so RTOG, a high grade, 3 acute and late GI toxicity, and post-op party, it says increase in genitourinary toxicity also. So does nodal radiotherapy help? Approximately 25% of radiologically node negative patients have pathological disease on extended pelvic nodal dissection. So because of that, the retrospective study has shown benefit in patients with high risk of nodal mets. And however, 3 randomized control trials, they have failed to demonstrate any clear benefit. Those are RTOG 7706, RTOG 9413, and GTUG 01. So ongoing, yet to be reported studies are RTOG 0924, you said, and UK pivotal, and in India, POP-RT Astro 2020, it is the abstract has been published. So nodal volume demonstration, can you tell me what all node has to be included? Can be, what all node to be included in your nodal volume?
So we will include the external iliac, internal iliac, obturator nodes, pre-sacral.
Okay. Any, like, at what level it will start, until what level it should go, the upper level and lower level of the nodal volume?
Sir, it will start from L4, L5 according to the recent NRG guidelines.
And the lowest?
And,
lower border?
And the lower border.
Yeah, lower nodal level should be
S3, sir. Bony margin, sir, S3.
Okay, I'll allow it on that. So lymph node to be included, like distal common iliac lymph node, internal and external iliac lymph node, pre-sacral, as you said, S1 to 3, and the lowermost will be the obturator node, which will finish just above the femur head. So I'll explain on that. Superior extent is L5S1 in RTOG study, and pivotal study, it is lower border of L5. Lower caudal extent of external iliac lymph node should be top of femoral heads in both the trials. So it should be the lowest contour included in the, for the external iliac node should be top of the femoral heads. Pre-sacral space S1 to 3 inclusive of 10 millimeter strip, and it has to be connected. Connecting the internal iliac nodes and external iliac node, to connect there should be 18 millimeter strip medial to the bony pelvis, which includes the small vessels of the in the planning CT scan. So few slides about the nodal contour I have included. So place 7 millimeter margin around the iliac and connecting external and internal iliac contours. Connecting strip has to be 18 millimeter wide. Presacral lymph nodes S1 to S3 with a 10 millimeter strip anterior to the sacral bone, carving out bladder, bone, and bowel. Stop operative lymph node contouring at the top of the pubic symphysis. Stop external iliac lymph node contouring at the top of femoral head. So that should be the lowest. Now coming to the margin, what should be the margin on PTV primary and PTV node? Let me ask. I think I have asked everybody. Avinash, Apik, Janvi. Dr. Lowry?
Yes, sir.
Tell me the margins.
So, PTV margins. Yes. PTV margins vary from institution to institution, but as per the guidelines, ISTRO guidelines, and all in our institution, basically the movement in prostate we see translational and rotational movement, and to account for that, we give 1 centimeter margin all around, and 7 mm from behind.
Okay. Everybody would agree to that, or any difference in opinion?
Yes, so 7 millimeter. It definitely depends upon the institutional protocol. As our institute, we have seen that 5 millimeter margin is sufficient with daily cone beam CBCT. So we usually take 5 millimeter margin for prostate.
Okay, so
I like to put the input, sir.
Yeah, Vinas.
We follow a 7 mm margin. We do give a 3 mm expansion to the CTV also sometimes. And apart from that, we give a CTV to PTV margin ranges from 5 to 7 mm. As guidelines says to carve out posteriorly, if the PTV margin is incorporating rectal wart, it has to be carved out. We, in our institute, we generally don't carve out that posterior margin.
So you take it 0.7 and 0.5, right?
Yes,
so if, as rightly said, if you are doing image guided RT, then daily volumetric image guidance is very essential. And because we are maintaining the bladder and rectum protocol, so then it has to be monitored regularly. And 7 millimeter around the prostate and seminal vesicle wherever indicated, and it should be 5 millimeter around the elective nodal volume. So, yeah, from my side, I think it is done, sir. Dilibhai, you want to add any question to any participants? Hello.
Actually, because I joined in the middle, so I'll take the feedback at the end. So nothing from my side. So I thank Dr. Manish and Munish, and thank you also for nice conducting the session.
Thank you.
Right.
Thank you, Dr. Sanjay Mishra and Dr. Dilip Parida sir, and all our participants for such an interactive and also informative group discussion. And I'm sure that many of our doubts regarding concluding margins are clear now, and it is particularly very helpful for the residents. So I think the winner of the group discussion will be discussed later, will be declared later at the end of the session.
So good evening, everyone. And I thank the organizers, particularly Dr. Manish Pandey, who's the program director, and Dr. Munish Gairola, the program chairman, for inviting me to moderate this group discussion competition. And as pointed out, that this is something new, group discussion competition. This is something new to me also, but let's hope we can make a good work out of it. And I've been asked today to speak on, or rather to moderate a session on, the topic is total volumes to be taken in different risk groups in CA prostate. And I hope my screen is now visible to everyone.
Not yet, sir.
Is my screen there?
It is visible, sir.
Hello.
Put it on present.
Oh yeah,
view,
it's
sir.
visible. Right. Okay. So just let me adjust it a bit. Yeah. So the topic is nodal volumes to be taken in different risk groups in carcinoma prostate, and I have a very distinguished panel of judges to help me with this. And we have Professor S.K. Srivastava. Sir needs no introduction. He's been a mentor to many of us here, a teacher to many of us here. He has been at the helm at Tata Memorial Center, Mumbai for many years. And presently he's a director at the SCG Center, Cancer Center in Mumbai. I welcome you, sir, to this group discussion. And our second judge is Professor D.K. Pareda. Again, sir is very well known to everyone, and he had long years at All India Institute of Medical Sciences, New Delhi, before moving on as head of radiation oncology at AIIMS, Bhubaneswar. I welcome you, Professor Pareda, to this group discussion. And we have a very young panel today to discuss this topic with me. We have Dr. Sumitra Barik, Dr. Avradeep Datta, Dr. Akash Pandya, Dr. Afreen Khan, Dr. Sankalp Naidu, Dr. Chandramouli, Dr. Avik Mandal, Dr. Avinash Badjena, and I hope all of them are here. I hope all the panelists are here.
Yes, sir. Yes, sir.
Yes, sir. So we can begin this panel discussion. So this is a panel discussion plus a competition also, and the judges will be observing our panelists and marking them on their responses. But let it be an open discussion, and I request all the panelists to come out with their experiences and with CA prostate and their protocols at their different institutes, because all these panelists represent all different parts of our country, and out of the box thinking is always welcome, because what is good science today need not necessarily be good science 5 years down the line. So a good healthy discussion is required. So the topic, as I said, is nodal volumes to be taken in different risk groups in carcinoma prostate. And if some of you have been following this Radonc Conclave, a lot of discussion has taken place over different aspects of prostate cancer treatment. And a lot of things have been discussed, and majority of the things which we are going to talk about today have also been discussed. There have been a lot of gray areas, a lot of debates, a lot of controversies which have been discussed. And I won't go into those things. I'll be strictly confining myself to the topic which has been given to me, and we will be talking more about how to go about the nodal volumes in different risk groups in carcinoma prostate. So first of all, let's talk about the risk stratification in carcinoma prostate, because as we all know that the treatment modalities and how we treat the patient is determined to a large extent according to the risk group in which the patient falls. So I would request the first panelist, Dr. Sumitra Barik.
Yes.
Could he give his comments on risk stratification in carcinoma prostate, or how they go about in their center in stratifying these patients?
Risk stratification. Yes, sir. Am I audible, sir?
Yeah, sure, you're audible. Yeah.
Yes. Risk stratification is done according to NCCN criteria: very low risk, favorable, intermediate, and unfavorable, intermediate, high risk, and very high risk group. In very low risk.
Could you speak please a bit loudly? Could you speak a bit loudly? Yeah.
Okay. The risk stratification done according to NCCN criteria, and the very low risk group, the T stage is T1C, and the Gleason score is less than equal to 6, and PSA is less than equal to 10, and at least less than 3 cores should be positive, and less than 50% of the malignant cell in any core, and PSA density should be less than 0.15 nanogram per ml. This is very low risk, and low risk is T1 to T2A, and PSA is less than 10, equal to 10, Gleason score 10. Every criteria should be present in low risk, and difference is the PSA density from very low risk and the less than 3 core positive between low risk and very low risk. Coming to favorable intermediate, it is T2
2A and B, and PSA score is 10 to 20, less than 20. And the Gleason score is 3+4, Gleason grade 3. And coming to unfavorable intermediate, it is T, T2A and T2B, and the grade group is here is difference from, that is the difference from the favorable intermediate, and the PSA score is 10 to 20. And coming to high risk, the T is T3A, PSA is more than 20, and Gleason score is 8 or 9, that is grade 4 and 5. And coming to very high risk, the Gleason score, the T is T3B or more, T4, and the PSA is more than 20, and the Gleason pattern is 5, and more than 4 core Gleason score have 8 to 10. This is altogether the stratification according to NCCN criteria.
So this is the stratification which you are following in your place of work.
Yes.
Oh, okay, fine. Dr. Avradeep is there? Dr. Avradeep Datta?
Yes, sir.
So what about Dr. Avradeep? Would you like to agree to Dr. Sumitra Barik on this stratification, or you follow something else in your institute, in your department?
Do follow the NCCN criteria. Other than this, if there is a node positive, there is a locally advanced group, and if it's metastatic, then it goes into the other group. Other than that, it's more or less the same.
Okay, so Dr. Pandya, Dr. Akash Pandya, there's a DMECO risk stratification also. So would you like to compare the two, and does it really have a clinical implication in the patient management when we talk about DMECOs or the NCCN? Are there any, does it practically make a difference how we stratify them as far as treatment is concerned?
Sir, NCCN risk stratification further divides the DMECOs low risk into very low and low, and intermediate into favorable and unfavorable. Sir, practically speaking, it does not make much difference when it comes to low and very low risk groups, but for intermediate groups, for favorable intermediate and this unfavorable intermediate, for the favorable intermediate group, we can offer the option of active surveillance to the patient if the active surveillance and observation to the patient, but that is not ideally done in the unfavorable intermediate group. We go ahead with the surgery given the expected life expectancy is more than 10 years.
Okay,
and
fine.
then
So
further, sir, high risk and very high risk group has been also been divided from the higher risk group of the DMECO, but that does not make any difference in this.
Okay, fine. So I think we all agree on the risk stratification, and it's almost standardized, but however, it has a lot of implications as far as the management is concerned. So moving on now. Okay, so next slide, yeah. So next thing which we can discuss is about the imaging of pelvic lymph nodes in carcinoma prostate, because we are going to talk more about the nodal contouring and the nodal volumes. So we have different modalities of imaging, as you know, CCT being the most common imaging modality being used by us radiation oncologists. Of course, now MRI is coming up, and we have PET in many centers. So CCT versus PET versus MRI, or any new imaging modality for pelvic lymph nodes. Maybe Dr. Sankalp Naidu can tell us what are their protocols and what is their imaging protocols in their institute and how they go about it. Which imaging modality do they prefer or they use?
In our institute, we go for a CCT and an MRI. In certain places, right now, PSMA PET is not available in all the places. If the patient is being able to afford it, we can do a PSMA PET in such cases to identify any radiologically negative, node negative in CCT and MRI can also be, it is even more sensitive. PSMA PET is even more sensitive in terms of that. So in our institute, we follow a CCT and an MRI to all the patients.
Okay, so you do a CCT and then MRI. So any particular sequencing you follow for MRI, or what kind of imaging would you use finally? MRI imaging would you use for your?
We go for multiparametric MRI, sir. We go for diffusion weightage imaging, and we see the ADC changes in which we can actually identify the exact area or site of the initial any small mesorectal lymph node is there, which will be masked, which will be near the prostate, which will be tough in diagnosis. In such cases, to exactly define a lymph node in these areas, we use multiparametric MRI in our patients.
Can I add, sir?
Yeah, sure. Please.
Multiparametric MRI is, I think, not required for contouring. If it is required in case of you are boosting to the a dominant nodule in the prostate. If it is just contouring whole prostate and lymph node, MRI T2 axial scan is good enough, I think. And regarding the lymph node, CT, contrast enhanced CT or PSMA PET, that will be good for contouring the lymph nodes. MRI will be better for the soft tissue prostate. Yes, we can see the lymph node in T2 and T1, but CT and PSMA PET will be better for lymph nodes.
May I add, sir?
Yeah, sure.
Sir, there is a newer modality of lymphotropic paraferromagnetic particles, which is being practiced in Netherlands, I guess. But it is under investigation and may improve the sensitivity of lymph node diagnosis in CA prostate cases.
So yeah, I'll agree with Dr. Parekh that multiparametric MRI is not really required for contouring. Of course, it has implications in the diagnosis of the patient, and but not exactly for contouring. And T2 weighted MRI might serve purpose for as far as radiation oncologists are concerned. So maybe Dr. Chandramouli, can he come in and can he tell us something about this patents, MRI and CT fusion? Are they practicing that at their institute, or what is their take on the imaging? Dr.
Yes, sir.
Chandramouli?
Yes, sir. Sir, we use CECT, contrast enhanced CT, routinely for both the primary disease evaluation and the metastatic disease evaluation, and MRI is also done for the local disease. During the radiotherapy planning, we combine and fuse both the MRI and the CT, so that contouring will be more accurate, and then the radiotherapy delivery will be more accurate. So
Yeah. So
can
Dr.
I add,
Mandal,
sir?
Dr. Yeah,
May
sure.
I add something, sir?
Yeah, sure.
Yeah, Soumitra, go ahead.
For patient preparation, contrast enhanced CT, but if you are doing only prostate only RT, then timing of contrast in this is important. Before 10 minutes before the scan, so that you can see the prostate invasion, tumor invasion in the bladder. But if you are contouring the pelvic lymph node, giving the contrast at the time of scan with a delay of 30 seconds probably, that will be vessel will be more visible, and it will be easier for contouring the lymph node if you are contouring the vessel based lymph node. And also patient preparation, we have to follow the rectal protocol and bladder protocol.
And we'll be coming to that. Yeah.
Okay.
You can carry on if you want to tell your protocol.
Okay.
You tell us about your protocol
Okay.
since you're speaking.
Rectal protocol is more important in CA prostate than bladder protocol. And for bladder protocol, we ask the patient to empty the bladder and drink 500 ml of water and wait for 30 minutes. Then we take the scan. For rectal protocol, patients should not be constipated, or the rectal diameter in the scan should not be more than 4 centimeters. That's what we see. And if it is more than 4 centimeters or patient is constipated, we suggest laxative, to take laxative and come on the next day and we scan again. That is the rectal protocol we follow, bladder protocol and rectal.
Okay, fine.
Thank you.
Dr. Avik Mandal? Yeah, Dr. Mandal, you are there. Okay, could you add to that what kind of rectal and bladder filling protocols you are following, imaging protocols you are following at your institute?
Yes, sir. For the bladder and the rectal protocol, we used to follow that the bladder should be moderately comfortably filled. Like we first ask the patient to void their bladder, and then.
Could you speak loudly? Could you speak a bit loudly?
Yeah. Am I audible now?
Yeah, that's better. Speak a bit loudly. Yeah.
Okay. So we first ask patient to avoid their urine, avoid their bladder, and then ask them to consume 350 ml of water, and bladder should be moderately comfortably filled, and it should be ensured that the same amount of the bladder filling is maintained during the entire treatment. Otherwise, it will introduce more setup error. And for the rectal filling, for the rectal protocol, we generally prescribe enema one day before and the same morning, and it should be empty. But we don't use rectal spacer, because the using of the rectal spacer might introduce error, and there will be chance of missing the posterior part of the prostate. And for the CT and MRI, it is better if the MRI is done on the same treatment position, like with the cast, thermoplastic cast, or if we are using the knee rest. Otherwise, it will again may introduce the setup uncertainties.
Okay.
May I add something, sir?
Sure.
Dr. Amit, Dr. Avardeep and Dr. Akash Pandey wants to say something. They have raised their
fine.
hands.
Okay, fine. Dr. Avardeep, please.
Yes, regarding the modalities of contouring the lymph nodes and the primary, we generally in our center fuse an MRI, generally the T2 weighted images, and the other parts of the multiparametric MRI, the dynamic contrast and the diffusion weighted, we generally do not fuse until and unless we have some issue with not being able to identify the lesion properly, except especially in cases of capsule breach, because then the picture changes somewhat. Other than that, the MRI is only for the primary in our setup. If we are having gross nodes in the CT scan itself, we generally do not go for a PET, the fusion of the PET. But if we are having a lymph node which we are not being able to categorize properly as being malignant or not, then only we go for a fusion of a PSMA PET to properly categorize if it is a metastatic lymph node or not.
May I add, sir?
Okay, just wait. Let's go to Dr. Avinash first. Dr. Avinash, you are there from AIIMS Bhubaneswar?
Yes,
okay.
sir.
So, Dr. Avinash, what about your institute? CT MRI fusion is done routinely at your institute?
Sir, we do take the MRI of patients and we look at the T2 weighted images for the delineation, but we generally not fuse when you are planning for any conventional or moderate fractionations. But when there is any SBRT plan for any patients, in that case only we do fuse. But in other scenario, having a conventional or a moderate hyperfractionation, we take the MRI help. We generally don't fuse, but we take the help of MRI to look into any extracapsular extension. Take the help of any radiologist. That the required help we take from MRI. But generally we don't fuse unless until we are planning for any SBRT.
Okay.
May I add?
Yeah. Dr. Pandey.
May I add?
Sir, about the imaging modality and fusion, I think my colleagues have covered everything. But I would like to comment on the imaging protocol and slice thicknesses. For
we will okay, fine, yeah, okay, slice thickness, okay, good.
Sir, the slice thickness should be less than or equal to 3 mm, but ideally 1 mm. In our institute, we take a slice thickness of 1 mm without any gaps to adequately identify the extension of the primary disease in the MRIs.
So what is your superior and the inferior most extent of imaging with 1 mm slice thickness? From where would you start your imaging and where do you end it?
Sir, we generally start just above the seminal vesicles for the superior border and end it below the penile bulb for the identification of the primaries.
May I add, sir?
Okay.
May I add, sir?
Yeah,
May
sure.
Okay. For slice thickness, we take 2 mm slice thickness, and 2 scan we can take. One scan with 2 mm slice thickness from the pubic symphysis to the femoral head, top of the femoral head, and another scan, 5 mm scan from umbilicus to the 10 centimeter below testis. 2 scan we can do for planning also. And for CT and MRI fusion, the MRI and PSMA PET should be in treatment position, also follow the same bladder and protocol and rectal protocol. It's not easy to fuse the PSMA PET. Sometimes they do not follow the bladder and rectal protocol, but we can take help for the lymph node contouring. We can see the where it is taking up the lymph node, and we can draw accordingly on CT. It may not fuse also.
Amit, I think till now, Amit, Dr. Afreen has not been able to speak. I think she is quiet. So
okay, fine. Yes, sir. I think we have missed her. Okay, fine. I'm sorry for that. Dr. Afreen, you are there?
Yes, sir. Yes, I'm there.
Okay, Dr. Afreen, you are from AIIMS Bhopal. Okay, so you are having the facilities for MRI, CT, and PET at your place?
Sir, not PET, but MRI and CT is there available with us.
Okay, okay, fine. And so you agree with the other panelists that about their imaging protocol, or you have something to add to it?
Sir, I agree to that. Agree to this because we usually fuse MRI with CT scan, and I agree with the concept that MRI should be taken in the position which we will be treating further, like in simulation position, so that it is easy for us to fuse it with the planning CT. Because usually MRI is taken on a flat couch, in the curved couch, and we do planning CT in a flat couch, so that may cause difference in the anatomy. And bladder rectal protocol also I recommend that we should follow during MRI as well.
Amit, Dr. Parida has some suggestion.
Yes, sir.
Dr. Amit, when anybody is adding to your questions, you are actually putting your question to a primary, to actually one candidate. And if somebody is adding, please tell them to take their name. Otherwise, we cannot see them on the screen.
Oh, okay, sir. Okay, I'm sorry for that. Okay, whenever we put a question, I'll ask them to say who's speaking. Right, sir. Right. Okay. So, Dr. Afreen, continuing with that, how do you do the imaging? First, you do the CT scan, or first you do the MRI, or what is the gap between the CT and MRI?
So we usually prefer MRI in prostate cancer. And if we suspect any regional lymph node metastasis, we go for CCT to identify whether any other regional lymph nodes are there or not. And PSMA PET and all, it's not commonly available over here, so patients usually don't get that. So this is more than enough for us to fuse MRI and identify the regional lymph nodes for contouring.
Okay, okay, fine. So I think
Okay.
with the imaging part here, and I think we'll move on. So let's go. So this is just to show the ESMO algorithm for prostate cancer, and we have already discussed the risk stratification and staging and all these things. So I think we can move on.
Add a little bit on that.
Yeah,
Amit. Yeah. So what is happening? Many times people are raising their hands, and I think we cannot see everyone.
Yeah, I think, sir, that was my problem. So now I am able to see them who all are raising their hands. So
yeah, so maybe what they can do, do in the reactions in their screen, and there is a raised hand somewhere, I think. So that can be done so that you can see later on.
Right, sir. I think I'll now I've opened that sub-screen on my, so I'll be able to see who all are raising their hands, and I'll accommodate them, sir.
Okay, sure.
Right. So let's go now to the lymph node involvement. Let's talk a bit about lymph node involvement in prostate cancer. And since we are talking about nodes, the first thing when we look at imaging is that what would constitute an enlarged node or an abnormal node. So we have to be sure before we go in for any contouring or we go in for any dose prescription to a particular volume. So I think Dr. Avinash again from AIIMS Bhubaneswar. So what in prostate cancer would you consider when you're seeing the pelvic node as an abnormal node or an enlarged node? What's your take on it? Or what you follow in your institute? Dr. Avinash?
Yes, sir.
And kindly, as Dr. Pareda suggested, please tell whenever you are saying, just all of you just take your name before answering the question so that we know who's speaking, right?
Yeah, I'm Dr. Avinash from AIMS Bhubaneswar.
Yeah.
So I'm taking on that question. So we do look into the enlarged node as it should be more than 1 centimeter. If a CT is taken, it should be more than 1 centimeter in short axis diameter. Or else, if there is any extracapsular extension or any fat stranding outside the pelvic lymph node, so that is also looked into. These are all the things which we look into to constitute the enlarged lymph nodes.
May I add, sir?
Okay.
Dr.
Just
Soumitra
hold on.
from-
I think we need to I want to put something. Actually, everybody is raising their hands, so it will become very difficult for me to really move ahead if all of you keep on raising your hands. So let me go through it. Let me ask you questions, because we have a time constraint also, and if all of you keep on raising your hands, then it will become very difficult for us to keep within the time frame which we have been allotted. So I think what I am going to do is I'm going to give you all of you an opportunity on a particular aspect what we are going to discuss. So I think I won't be able to see all, because all of you are raising your hands, so it becomes difficult for me, right? So okay, fine. So now talking about the same thing about abnormal nodes. Again, I'm going back to Dr. Barik from RGCI Delhi. What's your take, Dr. Barik, on nodes? You heard Dr. Avinash. So what's your take?
On CT scan, the normal hilum, fatty hilum should be lost, and short axis diameter more than 1 centimeter, and the margin extracapsular invasion should be present, and the margin of node is irregular, and the shape of the node is round. That most likely it is malignant. And on PSMA, also PSMA more than 5 mm, and there is PSMA uptake more than 2.5. That is actually not very standardized, but PSMA uptake and more than 5 mm, that may be considered as malignant. Similarly, on MRI T1 contrast, there should be enhancement, and T2 there will be enlarged node you can see in the fatty space.
So can I add, sir?
May I add something, sir?
From Dr. Okay, Dr. Mandal, you want to add something?
Yes.
Can I add, sir?
Okay, Dr. Mandal. Okay, Dr. Mandal first.
Yeah. Apart from the characteristic findings of the enlarged lymph nodes, there are differential size criteria as well. For the just like for the pelvic lymph nodes, like the internal iliac and the orbital lymph nodes, even the 8 mm cutoff we can consider. But for the perirectal, mesorectal, and the presectal group of lymph nodes, even the 4 mm cutoff is recommended as per the recent NRG consensus guideline. But if we go above in the abdominal group of lymph nodes, then 1 centimeter is okay, I guess.
So can I add to this, sir? Can I add to this, Dr. Sankalp?
Okay, Dr. Sankalp, what do you want to add?
According to the NRG guidelines, which has been released in 2020, it has specified the exact cutoff values for lymph node enlargement in CT and or MRI. For internal iliac and obturator group of nodes, it has told a cutoff of short axis of more than 7 mm, and if at all, if there is any irregular border and or any heterogeneous morphology. For common iliac and external iliac, they have a cutoff of short axis more than 8 mm. For lesser mesorectal and prerectal, they have a short axis of more than 4 mm. And if they are having any irregular borders and any heterogeneous morphology. In PSMA PET, if there is uptake greater than the blood pool, it is considered along with these three things, it is considered as a positive lymph node enlargement, according to the latest NRG guidelines.
Okay.
Amit, can I add something before? I mean, this is what
sure.
is happening, that I mean, people are jumping here and there. My suggestion will be that suppose you have asked the question, I mean, there are 8 candidates.
Yes, sir.
And you have asked the question from, say, if, for example, asked the Soumitra, and Soumitra has given some answer, then you can ask the next one, Avardeep, Akash, Shafrin, Sankalp, Chandramouli, and Avik, if they want to add something, or that remains the same, right? And second question will be from Avardeep, and then you will go for Akash, Avdeep. So that same rotation will continue And
Oh,
if
yes,
they
sir.
want to add something, they will add. Otherwise, they will keep quiet till that
Oh,
time.
yeah, sir.
Yeah?
Because everybody is raising their hands and everybody,
Right,
so
yes.
that's becoming difficult. Yeah.
Absolutely. Everybody has something to add. Definitely,
Yeah.
that's very nice.
Right, sir. So that's
Yeah.
how we continue. So,
Right.
so Doctor, let's go to Dr. Avradeep now. Dr. Avradeep, regarding these nodes, you have anything further to add to what has already been said?
Just one point, that a previous history of the patient should always be taken into account before we are just going with the size criteria, because some of these patients might be presenting to us with a catheter in situ because of the dribbling, or they might be presenting to us with a previous history of TORP. So these patients might be having an underlying infection and maybe a few inflamed nodes here and there. So a 4 mm criteria for correlating from the energy guidelines is all well and good, but the previous history of the patients and other factors also need to be kept in mind before terming these lymph nodes as positive just on the size criteria, especially if we are having the help of a PSMA PET, which is not available at all centers, but if we do have it, we should take advantage of it.
Okay, fine. So after this, Dr. Akash, I think you've already spoken on this.
No, sir, I haven't
okay,
spoken,
fine. So
but
Dr.
I think
Akash, yes.
everything has been, whatever I would like to say has been covered by my colleagues.
Sure, that's fine. I mean, it's okay. Dr. Afreen?
Yes, sir. I think everything has been covered, and NRG latest update has been covered. That is the most important thing. And like Avradeep has said, we should obviously take the previous history of infection that may cause inflammation of the nodes here and there. That's all, sir.
Okay. Dr. Sankalp?
Sir, I've told the guidelines. I don't have anything from my side, sir. Yeah. And
okay. Dr. Chandramouli?
Yes, sir. Sir, I would like to add that central necrosis can be a feature of malignancy. And as told by others, whenever possible, we have to add gallium. We use the gallium-68 PSMA PET scan to differentiate infective versus malignant node whenever the size is borderline, like 8 mm or
okay. Dr. Chandramouli, have you gone through the recent NRG guidelines, very recent guidelines 2020, in which they have outlined all the different modalities and how you interpret the size in different modalities? Are you aware of that?
Yes, sir.
You've seen that paper?
Yes, sir.
The NRG oncology paper. Okay, fine. Good. So Dr. Mandal has, I think, already talked on this. And Dr. Avinash, you have anything else?
No, sir. I think everything has been covered.
Right. So I'll just show you this slide. So if you look at 2006, I mean, this paper from 2006, the life was much more simpler, and a cutoff of 8 mm was used to define these nodes in prostate cancer. But as we move now to the current era, look at this paper which I was speaking about. So there are so many modalities now available to you, and every modality will have the different cutoff on how you interpret the nodes, your abnormal nodes and different cutoff. And this is a very recent paper. And I think all of you should go through, depending upon whichever modality is available in your center, and it takes you across all the spectrum of all those things. Okay. So what about the percentage of lymph node involvement in different risk categories? Again, let's go back to Dr. Barik. Dr. Barik, what will be your take when you are dealing with prostate cancer across the spectrum, the low risk, intermediate risk, high risk?
For low risk, the risk of involvement of a lymph node is less than 5%, 4% around. From intermediate and high risk, we use the Roche formula for lymph node estimated risk of lymph node involvement, that is 2.2 by 3 PSA and Gleason score -6 and into 10. If it is more than 15%, we treat lymph node for that, and that is the thing we use for percentage of lymph node, expected involvement of lymph node.
Okay, Dr. Avradeep, what do you think is the percentage? Which are the most common group of lymph nodes involved, which you will be seeing in prostate cancer?
Most commonly obturator and the iliac group of lymph nodes. But according to the latest papers, it has been seen that most of the failures, even after treating the nodes, occur in the common iliac and the lower para-aortic areas, as well as the perirectal areas. So it has been hypothesized that keeping the upper boundary of treating the lymph nodes at L4, L5 junction and covering the entire common iliac will lead to better results. So the jury is still out on that, I think.
And
But
what are the other nodes? What other nodes would be significant in your opinion?
May I add, sir?
sacral nodes.
Just Dr. Barik, no, please don't. Now we'll go one by one, please. Please don't interrupt in between.
The internal, external iliac, the presacral, the common iliac, and as well as the perirectal nodes.
Okay. Dr. Pandya, Dr. Akash Pandya?
Yes, sir.
What about, what's your take on these perirectal nodes? If we talk about different nodes which have already been said, which are all at risk, what about perirectal nodes? Do you have any specific comment to make on perirectal nodes? Why perirectal nodes are being talked about in prostate cancer when we talk of lymph node involvement?
So the perirectal nodes are these nodes are not routinely either dissected during radical prostatectomy or not even contoured sometimes, unless it is proven to be involved. So many of the failures are seen to be in the perirectal nodes. It is just following the obturator and the iliac nodes. So this has to be an area of, it is still an area of ongoing investigation.
Okay. But Dr. Afreen, you have something to add to that? On the
Sir, yeah, I agree with Dr. Akash. Sir, the perirectal nodes are actually not being dissected, and during contouring also we don't take into our planning. So we have seen that the failure and recurrence are mostly seen in perirectal nodes, para-aortic, paracaval nodes as well. So these are ongoing trials on perirectal nodes, involvement should be there or not in the planning.
Okay, Dr. Sankalp, what's your take on the nodal profile in CA prostate along the different risk categories?
The risk categories, we follow the Roche formula to see the lymphatic LV invasion. We see that we either put it into low risk or high risk. For high risk, low risk is less than a cutoff of less than 15%. More than 15%, you consider it as high risk. There's one more thing that 15 to 35% was considered as intermediate, and more than 35% was considered as high risk. But the actual risk is almost 40%. And along with Roche formulas, in the American guidelines, they follow the Partin's tables. The Partin's table exactly uses clinical features of prostate cancer, especially three. One is serum PSA, the Gleason score, and the clinical stage. So you have to add these specific variables on the side, and we can know the approximate percentage. It can predict whether it has gone beyond the prostate or not. So along with this, the one more question which I'd like to add is that you have told about the mesorectal group, pararectal group of lymph nodes. These are the sites which are normally not properly covered in the guidelines. So, and these are the sites of normal recurrences on the long-term studies. So,
okay. Yeah, that's fine. We can go to Dr. Chandramouli. Dr. Chandramouli.
Yes, sir. Sir, I would like to tell that generally we cover the external iliac and obturator group of lymph nodes and the internal iliac hypogastric group of lymph nodes and the presacral group of lymph nodes. Presacral, we cover the subaortic region mainly. Okay. And regarding the upper border, we are keeping at that L5S1, so that the distal common iliac is also getting involved, is also covered. So the thing is, now recently RTOG 0924 trial, they have tried to cover up to the L4, L5 intervertebral junction. So these are the common region lymph nodes. Having said that, perirectal lymph nodes, whenever involved, should be contoured and then given a 1 centimeter margin to the GTB, as usual, according to the ICRU guidelines, and then accordingly covered. So, but the AGCC doesn't give perirectal, doesn't specify perirectal as a regional node. So, yeah. So that's it.
So, Dr. Avik Mandal, continuing with the discussion, have you ever used Partin tables in management of CA prostate, or you go with the Roche formula, or have you
Roche
aware
formula
of
the MSKCC nomogram, which is available online.
Okay.
Right.
Okay.
And for the sir, for the perirectal group of lymph nodes, I just want to add a few points. That there is one study which evaluated total 32 group of lymph nodes in the abdomen and the pelvis, and they found that perirectal group of lymph nodes, there are almost 10 to 11% of nodal recurrence in the post-operative cases, and if T3 disease, if the disease was infiltrating or abutting the rectum. So I think the latest energy guideline has recommended to include the perirectal group of lymph nodes if it is T3 disease or if it is the post-operative cases, and if the disease was already abutting rectum.
So, okay.
Dr. Amit, Dr. Amit, please try to summarize. Dr. Rath has joined for inaugural session. We are getting ready. So please try to summarize.
Dr. Avinash?
Yes, sir.
Anything you have further to add to this?
No, sir. Same as before, just...
Okay, fine. Okay, fine. So going to when do you treat the nodal volumes in prostate cancer? I think we can, Dr. Avradeep, can you take that?
Yes, we treat the nodal volumes for low risk. We generally do not treat the nodal volumes in our center. For intermediate risk, we generally go by the Roche formula. If the percentage of lymph nodes, especially for the high intermediate risk, we generally avoid treating the low intermediate risk if possible. If the Roche formula, we are getting a lymph nodal frequency of more than 15%, we go for treating it. And as well as for high risk patients. Coming to that, most of our patients in our center are generally present with high risk disease, and we generally treat the lymph nodes, and we treat up to the common bifurcation of aorta, from the bifurcation of aorta. We do not treat from the bifurcation.
Dr. Barik, you have something to add to this? When to treat? What are the indications of treating nodal volumes in prostate cancer?
We treat in intermediate risk if the estimated risk of lymph node involvement is more than 15%, and we treat high risk. And if the clinically frank node is positive, present on imaging, there is frank node, malignant, probably malignant node is positive, then we treat the nodal volume. For nodal volume, we take the proximal common iliac also from bifurcation of aorta, external iliac, internal iliac, obturator, and presacral up to S3. And these are the nodal volume we treat.
Okay. Dr. Pandya, you have something to add to this?
Sir, as for the indications, I think everything has been covered. I would just like to comment on what we practice at our department. We usually start contouring at L4, L5 junctions, or at the bifurcation of the aorta or this inferior vena cava. And for the presacral nodes, we continue up to S3. And we generally include obturator nodes also. And for the ending of the external iliac, we end it at the level of where it leaves the pelvis and reaches the...
Dr. Afreen, you have something to add?
So almost same. Nodal volume will be treated if there's a gross disease.
Okay, fine,
or
fine, that's fine. If you have nothing, if that's okay, that's already been said. Dr. Sankalp?
So everything is the same. I just would like to add the upper border and the lower border, which varies in different institutions. We go for L4, L5 junction. Up to the lower border, we go like on top of the pubic symphysis. We like contour the nodal volumes according to RTOG 9413 trial. We go for that.
Dr. Chandramouli, you have something different?
Yes, actually, regarding this adjuvant radiation to the prostate cancer, when there is a post-op histopathology showing lymph node positive, this lymph nodal volumes can be covered. And regarding the radical, we irradiate when the Roche formula is more than 15% predicted risk of lymph nodal involvement for the high, intermediate, and the high risk patients.
Okay, Dr. Mandal, anything else you have to add other than what has been said?
Yes, sir, already it's been discussed.
Okay. Yeah, Dr. Avinash?
Yes, sir. Just want to add something. At our department, what we practice is just the upper border. We take L4, L5, which varies in different institution to institution.
Okay. Okay. So let's go to this. So what do you think is the standard of treatment in your centers? Do you practice conventional versus or IMRT or VMAT for prostate cancer? Does everybody has IMRT at the centers? Dr. Barik?
Yes, we have IMRT, 3D.
So you are practicing IMRT. Of course, I know Dr.
And at least IMRT and VMAT also.
Okay,
we'll
fine.
have benefit of VMAT little bit of lower dose to the rectum, and IMRT VMAT will have low dose to the bowel and
Dr. Avandeep, of course, we are doing IMRT here, that I know. Okay. So, Dr. Pandey, at your center, you're practicing IMRT for prostate, or you do conventional treatments?
So, we practice IMRT with image guidance, daily CBCT.
With image guidance, very good. Dr. Afreen?
So, we practice IMRT with daily imaging, IGRT. With CBCT, we do daily CBCT.
Dr. Sankalp?
So we go for IGRT with daily CT on a daily basis. Yes, sir.
And Dr. Chandramouli, same?
Sir, we go for IMRT or VMAT with IGRT and weekly CTCT.
Dr. Bandal?
Yes, sir. We also follow the IMRT or VMAT. In fact, the
Right.
conventional boost is strictly no for the prostate boost.
Okay. And Dr. Avinash?
Yes, sir. We do follow the image-guided IMRT also. Yeah.
Yeah, okay, fine. So there's a consensus that everybody is doing the latest modality treatment. So, okay, so there are differences between RTOG and pivotal guidelines, and I think these are very elaborate. We won't go into this because there's a constraint of time, because this will take a lot of time. However, if you go through the papers, it has been elaborated how the RTOG and pivotal guidelines are different. So we won't go into this, and there are a lot of other issues with the contouring, but I think the time is very limited, so we will skip this. Okay, we'll just go quickly to the dose prescriptions and dose schedules. So what's the take? Conventional radiotherapy versus hypofractionated in your centers, Dr. Barik?
Amit, we have
what's your practice?
Dr. Amit, we have separate lecture for this. So we can skip this to be in the time.
We practice conventional.
So I think then we can stop the discussion here, and I'll thank all the panelists who were there and who presented, and I'd like to thank our judges, Professor.
And I will thank you all, and I will thank you, Amit, to you because you have given a light to us, and we will try to conduct further more program for senior residents only, so they will get proper time. Thank you.
Right. Thank you.
Thank you. Thank you.
Thank you.
Thank you.